So, welcome everyone. I declare open this hearing of the Joint Standing Committee on the National Disability Insurance Scheme for its inquiry into the NDIS participant experience in rural, regional and remote Australia. I'd like to begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present, and I extend that respect to Aboriginal and Torres Strait Islander people with us today. We will be conducting today's hearing in person and via video conference, and I have with me Deputy Chair Senator Hughes, along with Senator Urquhart and Senator Sharma. We also will have with us today Ms Payne and Dr Ryan later on today. So these are public proceedings being auto-streamed live with open captions via the Parliament's website, and a Hansard transcript is being made. I would like to remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as contempt. It is also a contempt to give false or misleading information or evidence. Witnesses also have a right to request to be heard in camera. The Senate has resolved that an officer of a department of the Commonwealth or of a state shall not be asked to give an opinion on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. If a witness objects to answering a question, they should state the grounds upon which the objection is made, and the committee will determine whether it will insist on an answer having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. That has never occurred before, so it sounds very formal, but you know, it's unusual for that to ever be applied. I remind committee members and witnesses who are appearing via video conference and who are not speaking to mute their microphones. Could I please remind those contributing that you cannot divulge confidential, personal or identifying information when you speak, and if you wish to supplement your evidence with written information, please forward it to the Secretariat after this hearing. And can I ensure that everyone has turned off or turned their mobile phones onto silent? On that note, I would like to welcome representatives from Blind Citizens Australia who are joining us via video conference, and Vision 2020 Australia. Mr Craig, welcome. And I understand that information on parliamentary privilege and the protection of witnesses given evidence for Senate committees has been provided to you. And for the Hansard record, could you please state your full names and the capacity in which you appear today? If we start with yourself, Mr Craig, if you'd like to introduce yourself, and then we'll go to Blind Citizens Australia.
My name is Jonathan Craig, and I am Policy and Advocacy Advisor for Vision 2020 Australia.
Thanks very much. And Blind Citizens Australia, if you'd like to introduce yourselves.
Good morning, everyone. I'm Corey Crawford. I'm the National Policy Officer at Blind Citizens Australia.
Thank you. So we'll begin, if you would like to make an opening statement, Mr Craig. We do have a second person online. Would you like to introduce yourself as well?
Hello, my name is Ross Herford. I'm on the National Policy Committee for Blind Citizens Australia, and I'm coming to you from the Sunshine Coast in Queensland.
Oh, well, to be where the sun shines.
Very jealous.
Thank you for being with us today. Mr Craig, would you like to begin?
Is there another person online?
Yes, it's Mark Warrington. I'm from Blind Citizens Australia, the National Policy Council, and I'm coming to you today from Hobart.
Well, there we are. We have a good selection
Beautiful
of people.
Hobart.
Yes, and Senator Urquhart says hello to you. Yes, sorry, apologies once again, Mr Craig. Over to you.
Yes, I'll just say something brief. Good morning. Thank you so much for having us this morning, and it's excellent to also have representatives from Blind Citizens Australia on board. I really appreciate your time, and I'm looking forward to this morning's conversation. I guess, just for a bit of context, I think one of the key things to think about is that blindness and vision loss in an NDIS context is a low incidence disability because the vast majority of vision loss actually occurs in older age. So that means that there are around 2% of participants, that's around about 10,000, fairly consistently have visual impairment as their primary disability, and then a further 2% report visual impairment as a secondary disability. So that's a small user group, and they're very widely geographically dispersed across the country. And the impact of that is that somebody might live for a very long time without ever having met another person who shares their situation. A person might grow up in a town where there is no other person who is blind or has low vision. And also, it may be very difficult for them to access service provision. There are a small number of vision service providers who are providing service to people all across the country. And there's an additional problem to think about as well, which is that with a lot of disabilities, people can come to Metro to get, training or OT or things like that. But with blindness and low vision, often the service has to be delivered where the person is. So that means a good example is orientation and mobility services, which is teaching you your route to your local bus stop, or how to get around safely in your town and go to work or go to the shops. You can't really do that in a clinical setting, so you have to do it where the person is. So I guess I just wanted to begin by giving a little bit of that context. Thank you so much.
Yep, thank you very much. And now, would Blind Citizens Australia like to put forward your opening statement?
Thank you. It's Corey Crawford here. I'll just quickly add to Jonathan's point. I'm coming to you from a suburb in Western Australia called Baldivis. So that is about 40 kilometres south of Perth and about 25 kilometres north of our secondary city, Mandurah. I'm sure you're aware, but you can fit the entirety of Western Europe into Western Australia and still have room left over. All West Australians feel quite a long way from Canberra, but there are also a great many number of West Australians who are a long way from Perth, and that is especially so for people with disability. We live in geographically a very large country, and that is one of the reasons why we're here. It is very difficult to get services into rural, regional and remote areas. I'd just like to thank you for having us all, and we'll do our very best to answer any questions you may have. Thank you.
Well, thank you very much. Is anyone else wanting to add to those words? No? Okay. So I want to thank you for taking time to be with us today. We know that people who live in regional, remote and rural settings who have disability often find it very challenging. We have already been to Darwin and Broome, and it exposed a number of issues around services for people in remote communities. We're really wanting to get a clear understanding from you of what the key challenges are and your suggestions for how we overcome them in a practical way. And so far we've heard that there are real challenges with getting staff, getting people who are qualified into those remote communities, and also we've spoken with many First Nations people, and we've found that for them there's some particular barriers in terms of culture and language. So a question, if we could start with yourself, Mr. Craig. From your perspective, what other, if you had to name, say, you mentioned about, you know, getting around and having someone on the ground to help someone who is visually impaired to get about, even in their own community. What are the key challenges for someone with disability in a remote community? And have you got any suggestions for how we overcome those challenges?
Yeah, okay. So I think that one of the key challenges is actually even accessing the NDIS, because in order to get onto the scheme in the first place, you need to have evidence of your disability. And the way you do that with vision impairment at the moment is, via you meet the criteria on one of the access lists largely. And access list A, includes legal blindness, which means that you pretty much will likely get access. And then access list B includes a number of conditions. And the agency is very set on having, an ophthalmology report that shows what the diagnosis is. They're, very particular about the way that comes across. And so one of the big problems that we have is that an ophthalmologist will, let me step back one step. One of the big problems is that people in rural or remote communities often can't access an ophthalmologist very easily. There's lots of visiting ophthalmology schemes, and sometimes that helps, but they don't visit all communities, and the timing isn't always right. And so, they have to take a huge, often very expensive trip to a metro area to get an ophthalmology report. And then often we find that ophthalmology report is rejected, and sometimes it's rejected through, just minor administrative errors or things that haven't quite worked out, or perhaps like a misunderstanding between the clinical language that the ophthalmologist has used and the way that the agency, the person reading it, has received and understood what's been said. So, there's always stuff that we are trying to do to help ophthalmologists know how to do the access forms, but we think that there's a real potential benefit for, improving, as the review has recommended, creating a new access request form that guides people through the process a little bit more and would guide clinicians through the process a little bit more. And we think that there's real benefits to having this collaborative approach to thinking about how evidence of disability is gathered in the future, and whether there are ways to simplify that and get people, make it easier for people. Because, the real effects of this is very significant, and people can, we know of cases where people have spent, 8 to 10 months in this process where they've had to go back and get different ophthalmology reports. And the effect of that time is, we know of someone who said that they felt housebound in that time because they had no, they'd had no vision loss training before. So that's probably one of the really key challenges. And yeah, we would really like to see a collaboration between the optometry and ophthalmology peak bodies, which are our members, but also government, both the agency and Department of Health, to see if we could work through some of the barriers and problems and work through a process that would make it easier for people to gather evidence of their disability. Even things like linking the agency into My Health records, so that if somebody had gotten a diagnosis but hadn't realised that they would also need to get that NDIS application, they wouldn't need to do another trip back to Metro to then go through it with the ophthalmologist, if that makes sense. So even just little things like that. I feel like I've been talking for a long time, so I might just stop there.
No, look, thank you very much. Can you give us, for someone who lives in, say, a remote community, can you give me any sense of how do they receive services, say, in remote communities at the moment, and in a daily life of somebody who's vision impaired in a remote community? Like, is at the moment, do you feel that person is supported sufficiently? I know this is a generalisation and it will vary.
Yeah, it will vary, and I think perhaps the others. I'd like to hear from the others about this if you would. But I will just briefly say that I don't think that people feel genuinely that they're getting sufficient support, depending on where they are. And we, there's already service providers who are doing a lot of drive in, drive out for, fly in, fly out, even services in places like the Northern Territory. The cost of travel to those places is astronomical and is absolutely not being met by things like the modified Monash model that you're probably hearing about. And so, the results of that is people might have to wait months for their orientation and mobility session to know how to get to work. And in that time that they're waiting to know how to get to work, they're really, they really have to find alternate solutions, and they're living without independence. They're relying on somebody to take them, or relying on a support worker or something like that. And, that has an effect on the way that they feel as well, because they really, they know, if they've been on the internet, they know that someone living in a city is, has a cane or a guide dog, and they're, going around really easily, finding their way through, and they feel, a little bit frustrated or upset that they're not living up to that.
Can I ask you, just before I hand over to Senator Hughes, you mentioned there the Monash model. Can you give us a bit more information about that?
Yeah, there might be other people who talk to you about that, but the modified Monash model is this kind of thing that the agency has, where it can increase the amount of amount of funding for it allows providers to charge more essentially for travel, right, depending on where somebody lives, but. We would, and so it allows you. It classifies certain locations by remote, very remote, and there's another one as well. But I guess the problem is that it's not. We don't think it's sufficient. For example, there was Vision Australia, who wrote an excellent submission, also talked about a client for whom there needs to be a 5-hour round trip from Maroochydore to Menango in regional Queensland, and you can only charge for 60 minutes of travel under the modified Monash model for that.
Okay, so you see that as something that needs to be improved?
Yes, absolutely. But I would also just add to that, what also needs to be improved, which is absolutely crucial to this, is the way that planners think about travel costs when they're thinking about service delivery. So, for example, a planner might put in 20 hours of service, but if the provider then charges anything like the amount of travel it actually takes to get to them, then the amount, that 20 hours of service suddenly becomes 10 or less, right? And this is often not considered by planners when they're putting in their hours, and then the provider has to is in this position where they either suffer a very heavy loss, or they have to tell the participant, I'm sorry, but what was promised in your plan won't be deliverable.
Thank you. Just before I go to Senator Hughes, I should invite members who are online from Vision 2020, from Blind Citizens Australia. Dr. Crawford or any other, would you like to add something to that?
Yes, thank you. Just to add to Jonathan's point, there was an example just last year. I spoke to someone who lives in Geraldton, which is a fairly well-known regional location in Western Australia. It's a 10-hour round trip from Geraldton to Perth. He needed to visit an ophthalmologist to get a report. That appointment with his ophthalmologist, it only lasted an hour, so he needed a support worker for 10 hours with him to drive down to Perth. That's just an idea of how it works. Not in this particular case, but we have heard cases of people visiting ophthalmologists, and they're very expensive, as I'm sure you're aware. They're very well paid, as they should be. But there are instances where ophthalmologists only write 3-word reports. So it just gives you an idea of the level of expense that can be involved, and the people who have to travel great distances aren't necessarily feeling that they're receiving the best service, but it's something that they need to do in order to either enter the NDIS or remain on the scheme. So there may be other examples from Mark or Ross who may want to add to that.
Excuse me. Hi, committee. It's Ross Herford speaking. Thank you. I'll just talk about providers, if I might. So I'm a guide dog user, and I know we talk a lot about individual choice, and that is really important. But I've also experienced, and my friends have experienced, providers. I don't know how we describe it, but a provider can legitimately charge travel to 2 or 3 separate people in the same location or similar locations or close locations to deliver the same service on the same trip. I think there's opportunity here to find a really good balance and incentivise providers to deliver services together or with groups, or to deliver a service to multiple people in the same location, so that they can actually get better value. So a participant doesn't have to pay as much for travel for their service provider, and they get better value. I know you've been to Darwin, and I know people who live with blindness in Darwin. There's also no guide dog provider in Darwin, and dogs have to be flown up to be tested and trialled. There's really only one option. If that dog doesn't work, you're waiting months and months, possibly years. So incentivising, and I'll be specific here, guide dog providers to be more competitive and more national, because they are regional. They only operate within certain boundaries. And I think that's a constraint on choice for people to choose the service provider they need. But yes, I would like to see incentives for providers to deliver this innovative service that reduces travel cost and offers a better value. You know, you could go to a location more times to deliver services to multiple people at a reduced cost.
Well, thank you, Mr. Herford. That's good feedback for us. Thank you. Mr. Warrington, did you want to add anything?
Yes, thank you. I'd just say, so I have an acquired vision impairment. So up until 2021, I worked in remote Indigenous communities right across the Northern Territory and the East Kimberley. And I think of one person in particular when I was working at the community of Belgo in the Tanami Desert. He's blind. And the only services that I could see while I was working there, I was managing the store, but the only service that I could see that he was getting was through the aged care service. And he was a young fella. So I did wonder what was happening outside of that. Now, he was getting meals sometimes. And I think, yeah, what Ross is saying is really important from my experience, is incentivising people to get out into these rural and remote and regional areas, because, well, with that experience in mind, when it came to my vision and realising, well, I couldn't do the work that I could do before, and in the process of retraining myself, I realised that I had to move into a capital city in order to get the services that I needed. You know, I think yeah, that's a great point. Is incentivising organisations to step out of their comfort zone and really get out there into remote and regional areas.
So would you say, Mr Warrington, that many people who are vision impaired tend to end up moving to metro areas to get the services they need?
Those who have the option to, yeah. Not everyone has the ability. Because the other thing about, if you want to move in, all of a sudden you've got to pay higher rental costs than if you're living out in a regional remote area. Now, I'm sort of living in a suburb fairly close to the city here in Hobart, enjoying a range of services. I know I only have to go 30 kilometres out, and that suddenly things get a lot more difficult.
Thank you very much for that feedback, Mr Warrington. I'd now invite Senator Hughes.
Thank you.
To speak.
Thank you. Thank you for all being here today. For the sake of the committee, if you could sort of outline, I know you've mentioned ophthalmologist, but that would be a medical appointment. If you can perhaps outline what are some of the actual services that someone with vision impairment may be required to access or need to access.
I can take this first, and then the rest of you can add something. Jonathan speaking. I guess a few of the key ones are orientation and mobility training, as I mentioned before, which is training in the use of a cane or other devices and in strategies to independently navigate around your community. So that's a highly kind of specialist discipline that uses strategies around concepts like structured discovery and things like that. That's probably one of the key ones. But there's also...
Sorry, can I just interrupt,
Yes.
Ms. Craig? Would that be an OT who's specially trained or...?
There's a few different avenues to it. There's actually a separate postgraduate uni course that gets you into orientation and mobility services at this stage. But there have been various other credentials in the past. But it's more. Some OTs have transitioned to O&M, but it's a specialisation of its own, if that makes sense.
Yeah.
And then there's also more traditional type services, but with specialist leanings like occupational therapy, assistive technology, kind of training and advice, things like that. A lot of it is a lot of the vision services specifically fall into what you'd call the capacity building type category. And if those things are put in place well, it perhaps means that they don't necessarily need to have core supports as such a huge part of their plan. Interested if the others have any thoughts as well.
It's Corey here. I'll just add to Jonathan's point that people who are blind or vision impaired can access more general health services such as physiotherapy. That's actually quite common for Blind Citizens Australia's members to access physiotherapists. And I know it's not particularly the topic of discussion, Senator, but I think it's an important point to make nonetheless. A lot of people on the NDIS are very frustrated when they see a physiotherapist, for example, and they're charged twice or three times the amount that someone who is not on the NDIS would be charged. It's sort of seen as the NDIS equivalent of wedding tax.
Yep.
I can say that is very frustrating for NDIS participants because they are keenly aware that makes the scheme less sustainable, and it doesn't need to be that way. There need to be stricter parameters around how service providers in the allied health sector particularly charge. So I know that's not
look, it is actually
relevant,
part of it. It is part of it, and I think the point that was made earlier One of the concerns we've had and heard for years is the double, triple, quadruple dipping on travel, and providers charging participants. My son's a participant, and I had an OT tried on me, and she was told I didn't require her services because she wanted to come to our town and charge every participant travel, even though she was going to be seeing 7 or 8 participants in a day. So we know that this is an issue, and I also do appreciate you touching on what is effectively price guide issues. Again, we do know that, and look, I think some providers think they have to charge that. They don't actually understand that that's sort of the top and that's discretionary, and particularly to self-managed participants, it's an insult to be charged at the top of the price guide when in effect it's the carer or the participant themselves managing the plan. So I absolutely appreciate what you've said there. Just coming back to you, Mr. Craig, because you did mention the particular specialisation in these services, I am assuming, which is normally a mistake, but I'm assuming that it is incredibly difficult in rural and regional areas because, as you say, it's only 2% with a primary diagnosis and geographically dispersed, that just by the infrequency or the that specialisation would be almost impossible to get.
You're absolutely correct. So that's probably one of the key reasons why we do need to do fly in, fly out, things a lot of the time, because it's just, to have somebody stationed in a location where there might only be a couple of participants, is just not viable, really.
Yeah. And look, just my final question. I think in some ways the NDIS has lost a bit of its intent. It's in its name, insurance, yet we know that a lot of families struggle with proper funding for early intervention, which should actually then make it cheaper in the long run, but we're kind of cheating ourselves by not investing as early as we probably should. Can you give me an idea of what, for someone who is born with a condition that means that they're visually impaired or blind, like what are the early interventions that can be done that make a difference later on, or is it always going to be something that needs... is it a matter of invest early, save later, or is it something that's just going to be an ongoing condition regardless?
I think, I think it's absolutely blind and vision impaired people are the kind of key case study of invest early, save later, because if you invest in this training, if you invest in building somebody's independence early, especially for young children, then they're going to be in such a better position than they would have been otherwise. And that's why we sort of get frustrated when we see, plans that's like so much core support, because that, and even for like young children, because that's what people...
I think we are getting rid of the buckets, so I think that's the first step.
Yes. And I'm sorry to continue using the buckets, but just as a way of explaining, support work, like plans are very heavily weighted towards that, but because planners often aren't aware of what services, early intervention and independence building services are available, the result is that we don't always see them put in plans, and then people miss out on them. Sometimes even the families aren't aware of the fact that these services exist, so people can go a long time missing out.
Well, I guess a lot of parents, if they have a child that they've never had this condition in their family, of course they don't know. Yeah. And I promise this is my final question. Just to get a sense, if you were going to do best practice early intervention in an ideal world, and omit the travel side of it for me for a second, what would a plan? What would a sort of a rough dollar value be of a plan?
It's hard to say. I'm sorry to not.
I mean, is it 20,000? Is it 150,000? You know what I mean? Like,
It's not 150,000. It's probably between those. I think, at one point we did talk about how even just 25 hours of service would make such a huge, of capacity building service for a young child would make such a big difference. And we've even proposed that as like a foundational early intervention thing that that's pre-NDIS. So that might be a benchmark for you, but there's a few things that are dependent on that. So I'm sorry I can't be more specific.
Yeah. Has anyone else thought about that?
Senator, thank you. It's something I'm actually quite passionate about and has affected me personally. So thank you for raising this question. So when I was younger, I'm 30 later this year. When I was
You're
7,
still young.
8, 9, 10, around yes, thank you. Certainly younger than some of your colleagues in the US Senate. Yes, but when I was quite young, I was visiting my optometrist, and I have complex vision issues myself. She's a behavioural optometrist. She's brilliant. She's absolutely fantastic. But behavioural optometry 20 years ago was seen as being quite adventurous and not really mainstream in terms of the services compared to I attended Princess Margaret Children's Hospital, as it was at the time, our children's hospital in Perth at the time, and the services they provided were pretty poor, to be honest. I remember being quite traumatised actually, because they would have to pin me down to the bed and put in eye drops to sort of dilate my pupils, and sort of has contributed to a fear I have of hospitals to this day, unfortunately. Whereas my optometrist was brilliant. She conducted something which is called vision therapy. So that involves doing a whole range of techniques, and you learn different skills in terms of judging distance, coordinating the different functions of your eyes when it comes to your brain. You can sort of switch functions between eyes if you're taught how to do that. Ultimately, the effect of that is now I can drive a car. I played and umpired cricket at quite a high level. I do have complex eye issues, but unless you're an optometrist, you wouldn't know what they are. I am, effectively a sighted person. Had I not received that intervention 20 years ago, I would probably now have to be an NDIS participant. I would say that back then it was not covered by Medicare, and as far as I'm aware, vision therapy is still not covered by Medicare, but it is very important. Certainly in my life, it has saved the taxpayer probably tens of thousands of dollars. I can say in terms of costing, and it's changed a lot in 20 years, but when I was a little kid, I knew it was very expensive. My mum made sacrifices, but because she loves me, obviously, in order for me to receive those services, both in terms of in-person treatments, visiting my optometrist and doing the various skills and learning techniques and the like, but also receiving certain devices. So one of them, they were kind of space-age sunglasses, and they had different lights actually embedded in the lenses, and you would turn them on and they would light up and activate parts of your brain, and in order to help you coordinate your visual function. So as a result, I'm still benefiting from that to this day. So just, I am, I suppose, a living example of early intervention, and it actually can save money in the long term. And I know that is something that everyone who cares for the NDIS wants. We want it to be sustainable.
Yep.
But sometimes you do need to have those initial outlays, but it can save tens or even hundreds of thousands of dollars. At the time, it was considered that I was probably going to need surgery had I not received those kind of treatments, and obviously any eye surgery is very expensive, so that was all avoided by having the vision therapy. So hopefully that's an example you were looking for. Certainly in my life I have benefited enormously from early intervention.
Thank you, Chair.
Senator, it's Ross Herford. Do you mind if I...
No, please go ahead, although we will move on to other questions shortly. Go ahead.
Okay, thank you. So I just want to talk about some practical things that you might be looking for in terms of what intervention might look like for someone who's vision impaired or blind. And it is a stepped and staged thing. So I have a guide dog funded by the NDIS. So that's a good investment. Now, she gives me independence to be more mobile in my community. So with the right training, I can go more places independently. So that's the type of investment that then reduces the requirement for me to have a support person to help me navigate the world. That's how it does work and should work. But it doesn't remove that entirely, because I still can't go to the supermarket to do my shopping without a sighted person. Those things still need to happen even though I've got a guide dog. So while intervention can work, it doesn't remove the entirety of the requirement. I also use some assistive technology, which has also been funded by the NDIS. Now, my experience with that is the focus has often been on the technology and not on using it. So we go, here you go, here's the money, buy it, thanks very much, you might get an hour's training, whatever. But it's the application of that technology which delivers the benefits for someone who's blind, and learning to use the technology is what gives you the independence. And I find that that's often not considered as a part of this process. The more you use technology, the better you become at it. So I think when we talk about early intervention or intervention, we often forget that we have to start to use it, and we have to learn to use it and be proficient at it. And that's the bit that takes the time. I can also talk about things in my home. I can't use my washing machine independently because it's not really designed for me. But that means my wife has to do all the washing, and that's just not okay. Because I can't have technology for my washing machine, I then need a support person to come in and essentially
Press the buttons.
work the washing machine.
Yeah.
Yes, because I don't know. And I put it on the wrong cycle and all of that sort of stuff.
Look, you know, I can only imagine the trouble you get in.
Yeah. So this is where the nuance of vision loss is sometimes lost in a scheme the size of the NDIS. And that's been my experience as a user of the service, a guide dog user. I'm very thankful for everything that it provides for me. And I try and navigate the system as best I can and get out in the world. But it's some of those little things that create the problems, because I want to learn to use my technology better, and I want more technology. But it's the process to get there, and that I'm not given the opportunity to sort of learn it and embed it in my brain.
Thank you very much. I'd like to hand over now to Senator Urquhart.
Senator Sharma.
Oh, Senator Sharma, you have a particular question?
No, you go first.
You sure? Okay. Did you have some questions, though, Senator? I can leave some.
I can hold.
You go
Okay.
ahead.
Thank you. It's Senator Dave Sharma here. I just had some questions. I noticed a common theme in both the submissions from Blind Citizens Australia and Vision 2020 was about the accessibility of documents. I just wouldn't mind if you could elaborate a little on that, if you wanted to start, Mr. Craig, and just tell me about what your experience is about being able to access in an accessible format documents that help you understand the pathway through the NDIS.
Yeah, I think that this has improved over time, but we still could be better at this, which is providing documents in alternate formats, and particularly in the format that somebody has asked for. For example, somebody who has recently lost their vision might not yet be, an expert user of screen reading software or magnification software. So they might ask for their plan and letters or things like that in large print, and that's because that's what they're best able to use. Whereas, somebody like myself who was born blind and is very familiar with screen readers might ask for it would be fine with it in a digital format, but would prefer very much for it not to be sent as paper letter documents as it was, as my first plan was. So it's things like that, and I'll let Corey, cover some more detail as well.
Okay, thank you.
Thank you, Jonathan. Senator, I have a sad example, but it speaks directly to your point. The NDIS review, which I'm sure you're all familiar with,
Yep.
was inaccessible for people who are blind or vision impaired. There's a brilliant policy and advocacy expert at the Australian Federation of Disability Organisations. Her name is Lauren Henley. You might have come across her in your capacity on this committee or at other times. She is blind to a significant degree, and she relies on screen reader technologies. In her capacity as a policy expert at AFTO, she was unable to read the NDIS review for many months. Unfortunately, what happened was the NDIS review, the secretariat that existed in order for the document to be produced was then made redundant immediately upon publication, and so she had no one to contact, essentially, in order to let them know that the NDIS review documents were inaccessible. It sort of bounced around within the Department of Social Services. It took more than 6 months, and she reached out directly to the Minister for the NDIS at a function she was invited to speak at. They were on stage together, and she let him know. So it went to the highest levels of government, and even then it took months and months of wrangling with various bureaucrats in order to get an accessible format, by which time the NDIS review had been in public discourse for 6 or 8 months at that point, and the political cycle had moved on to a large extent. So that's just an example of things that can occur, and it's quite embarrassing when it happens.
Senator Sharma, can I just do a
Yeah, of
follow-up
course.
on that sort of waiting time thing? So I guess given that this inquiry is around accessibility of NDIS around rural and remote and regional communities, the waiting time that you're talking about there, is that because of rural and remote? I just wanted to draw us back to the sort of topic of what we're here for. And so I'm really interested in getting your understanding of, the waiting time for people to get assistance. So vision impaired people, then obviously prior to going on the NDIS, if you're in a rural and remote area, how long do you have to wait before you actually get that assessment, the assistance and the sort of things, and how do you manage your life, I guess, prior to that sort of coming to play? And I'm happy to throw that open. Mr. Craig, do you want to start?
Yeah, before you get on the scheme, the people that I've spoken to are often people who've acquired vision loss. Before you get on the scheme, it's very, very difficult to get help. It's because there is nothing that could make it, viable to bring services out, and none of the local services, have any knowledge really about vision-specific issues. And as for the waiting times, well, it can be, 6 to 8 months. It can be up to a year, and especially if the diagnosis is not clear and there's a process ongoing, and if for various reasons the plan is rejected, you just have to imagine the wait times expanding and expanding, and you'd have to imagine also, people are out in these communities without necessarily being able to personally talk to and meet with and learn from peers. So, the isolation and sense of loneliness that they feel, without, getting access to all of these things can be profound.
Senator Sharma?
If I could just ask just one more question. I was just talking about some of the services that you access under the NDIS. So you mentioned, I think, orientation and mobility training, physiotherapy, assistive technology, guide dogs. Just prior to the NDIS, how would these services have been covered by government, if at all? What did your landscape look like before the NDIS?
I'll be interested in other people's answers, but just very briefly, I will say, they were existed through like block funding and grant funding and things like that, but it was much more, it is, I think, better under the NDIS in some areas because, those services certainly did exist before, but their delivery was far more variable. But interested in hearing from others as well.
Okay, thank you.
It's Ross Herford here, Senator. Just on that point, my experience is that those services were done by charitable organisations.
Right.
For me, in Queensland, that was essentially Guide Dogs Queensland as the only provider of those services. My own experience and those of people I know is one of I would refer to it as at times begging. We had one place to go. It was a charitable organisation, and we had to do it their way, on their terms, and be absolutely thankful that it was there. The NDIS has allowed choice. Not as much choice as others, but there's at least choice.
Mm-hmm.
I can now go to different people. Orientation and mobility instructors are now going out independently and offering services directly to NDIS participants. That's a great outcome. If we can see better provision of guide dog services, that'd be good too, but it's a start. The NDIS has allowed a market to develop where the consumer is at the centre, not the charitable organisation, which has been my experience.
Yeah. Thanks so much, Mr. Harvin. Chair, I didn't have any further questions.
Did you have anything, Senator?
No, I think, unless anyone else wanted to comment on the question around, the accessibility. I think Mr. Craig touched on it fairly well in terms of, rural and remote, how you get assistance prior to getting, on the NDIS, but then how that changes when you actually are on the NDIS out in rural and regional. So I think, Mr. Craig, you touched on it very well, but I'm happy to open it up to others if you want to comment.
Okay.
No? Okay. You've covered it very well, Mr. Craig.
Look, I just wanted to say thank you so much on behalf of the committee for appearing today. Your insights are very valuable to this inquiry. I would like to say more broadly that early intervention is something we've touched on, and in those remote areas it is very important that that opportunity is provided. The federal government is very well aware that early intervention is important, and we are looking to the states and territories to deliver foundation services as well, because that is so important that we get in early. And in relation to the pricing schedules, I think that is something we're picking up on, because we all want the NDIS to continue well into the future. But it is pleasing to hear from you that the NDIS, while not perfect, is better than the system that was in place before, and our role is to make sure that it continues and that it improves in the quality and the delivery of services, not just in metro but out in regional remote areas. So thank you all very much for your time today. It's very much appreciated.
Thank you. If I could just quickly make one final point, it's that it's been an absolute privilege to be here and participate in our democracy in such a direct way. But if you had asked me to attend next week, I wouldn't have been able to, because this is actually my last day at Blind Citizens Australia. We put in ILC funding applications, and for various reasons, we have received half of what we had the year before. And so with half of our funding loss, it has meant that half of our staff have lost their jobs as of today. And it's very upsetting when we read stories and stories emerge in Senate estimates, for example, about NDIS funds being used to purchase illicit substances and the like. There is so much need in the disability sector for policy and advocacy work, and organisations like Blind Citizens Australia are really struggling. Thankfully, we'll be able to continue as an organisation, but I do know, as a result of some recent funding decisions and grant decisions, there are some really wonderful organisations that won't exist as of the next financial year. They just don't have any money to pay staff. I would just, yes, ask you please to advocate on behalf of us as advocates, because we want to make a difference. We want to contribute to our democracy. It's a wonderful thing to live in a liberal democracy like Australia. It is a privilege to be able to speak to you as our parliamentarians, but we need funding and not just sort of the 6 or 12-month contracts that people who work in disability advocacy often receive, but secure funding would be wonderful. So if you could please let...
Autism Tasmania was forced to close yesterday, and all its staff lost its job yesterday as well. So I'm sorry to hear that, Dr. Crawford.
And we take on board.
We
take on board what you say, and you've used your time very valuably, and we do hear you, and we do understand that we need to ensure that the dollars that taxpayers pay to the NDIS is put into where it is most needed. And we certainly wish you and the organisation all the very best in continuing to advocate for people who are sight impaired. So thank you for your time today, much appreciated. So now I'd just like to welcome representatives.
Leave meeting, button.
Welcome representatives from Rare Voices Australia, Neurological Alliance Australia and MS Australia, who are in the room with us today, and Limbs for Life Incorporated, who are joining us via video conferencing. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you, and I will just wait for everyone to take up their places before I ask you to introduce yourselves and make opening statements.
Front right-hand side. Should be directions on those chairs.
They are annoying.
I mean, they're all right for us. We know how to use them.
Well,
front right-hand side. Right in, yeah.
Thank you.
Everyone.
Yeah, thank you so much for being with us today. I would just like to firstly say that this is a regional remote rural inquiry into how do we better support people with disability in those communities, and so really looking forward to your expertise and knowledge and advice on how we do improve services into those communities. We have with us Senator Sharma, Senator Hughes and Senator Urquhart, and I'm Libby Coker, the Chair. And what I'd like to do is just invite representatives just to introduce yourselves, but also if you would like to make an opening statement. So first of all, representatives of Rare Voices Australia, would you like to make an opening statement?
Good morning, Committee, and thank you, Chair. I'm Fiona Lawton, the Disability Advocacy Manager from Rare Voices Australia. We would like to make a brief opening statement, if that's okay. I'm here with my colleague, Louise Healy, who's the Education and Advocacy Manager for Rare Voices. So on behalf of Rare Voices Australia, thank you for the opportunity. Thank you for recognising the rare disease cohort. This committee has previously done so through the report on the capability and culture into the NDIA. I'm here, as I said, Disability Advocacy Manager. I'm also the NDIS nominee for a gentleman with my son who has complex rare disease. And I also live in a part of regional Australia that is only accessible by boat or Medivac helicopter.
And where is that?
Macleay Island, Queensland.
Right.
So it's with all of that lived experience that Louise and I join you today. Rare Voices Australia is the peak body representing approximately 2 million Australians living with a rare disease. Of those 2 million, we estimate that 100,000 NDIS participants live with a rare disease comorbidity. The estimation is because the government is not currently tracking rare disease data at all within the agency. So of those 100,000, we're not sure how many live in regional, rural, remote, but we are reasonably confident that they represent the most intensive, complex and high plan value participants within the sector because of the comorbidities that we see in rare disease. Rare disease is often misunderstood in terms of the diversity, incredibly diverse, but when we contemplate the NDIS participants, just to give you a picture of who we're talking about, people living with Angelman syndrome, Prader-Willi syndrome, Fragile X syndrome, Huntington's disease, the range of muscular dystrophies, progressive, degenerative, very serious, in some cases life-limiting conditions, episodic, fluctuating, and very, very complex. From a Rare Voices perspective for the regional, rural and remote cohort, we are really strongly advocating for significant policy reform. We'd like to move the conversation from equity of access to equity of outcomes, because we understand that the significant barriers around thin markets and access is actually having a profound impact on the quality of outcomes for dollar on the return on investment for supports, therapies and products and services. So we are strongly supportive of the foundational supports as a trigger for a comprehensive review of both policy and practice within the regional cohort. And we believe that the universal design principles apply if we can design a system that meets the most intensive, complex participants with rare disease. We believe it will be equitable and effective for all participants, particularly living in regional, rural and remote. So thank you.
Okay, thank you very much. And just before we continue to questions, I'd also like to invite Neurological Alliance Australia, if you would like to make an opening statement.
Thank you very much. And as Deputy Chair of the Neurological Alliance of Australia and as CEO of Emerge Australia, the National Patient Organisation for people with ME/CFS and long COVID, I want to thank you all for the opportunity to present to you today. The Neurological Alliance of Australia is an alliance now of some 28 plus not-for-profit organisations representing adults, children and young people with neurological, neuromuscular and complex neurological diseases and conditions. We represent 1 in 6 Australians living with neurological conditions, and the impact on the Australian economy is estimated to be $100 billion a year. As CEO of Emerge Australia, I represent Australia's 250,000 people with ME/CFS and a further 400,000 people with long COVID or PASC. ME/CFS is a complex, disabling, invisible condition, and invisible is really crucial when we're talking about the NDIS, given it's the functional impairment that becomes the barrier for people being able to access the NDIS. And I note Fiona's comments about equity of access and wanting equity of outcomes. For people with ME/CFS and long COVID, the issue is equity of access, as I'll talk about later on. So people with ME/CFS have a very limited amount of energy, which is variable. Variable in that you can't tell. They might look all right, but when you see them, but then they crash. And in my experience, I've never heard of people crashing and not being able to get out of bed for 5 years, 10 years. But this is what happens to people with severe ME/CFS. Every time they have to fill out a form, appeal a decision, or attend an appointment, they draw on this limited pool of energy. If they overdraw, they experience post-exertional malaise, which can last for days, weeks, or months, and in some cases, years. 25% of people with ME/CFS are bedbound, 75% are women. Neither ME/CFS or long COVID discriminate when it comes to age, and unfortunately gaslighting and medical misogyny are rife in this patient cohort, and the treatment they receive from the NDIS is no exception to that. People living with ME/CFS often require care from a number of health professionals, depending on the presentation of their disease. This can include neurologists, cardiologists, physiotherapists, social workers, occupational therapists, to name a few. These are challenging to access for people who have very limited financial means, largely in metropolitan areas, let alone for people who are in regional remote Australia where those services are just not available. I'll talk a little bit more about the recognition of post-exertional malaise later on. However, what we are looking for is really the implementation of recommendations that have been put forward in the NAA submission. We need the NDIA to commit to educating and training staff and contractors about the various functional impairments that arise from being diagnosed with neurological disorders and progressive degenerative neurological and neuromuscular conditions, including issues of stigma and social inclusion, particularly as they relate to people in rural, regional and remote settings. We need the NDIA to develop and implement a set of guiding principles with a focus on invisible symptoms, not a focus on necessarily AIDS or those things that tend to define someone as physically disabled. We need the NDIA to introduce a substantial core group of staff. We would like a neurological community of practice to address the needs of patients, and we believe that these are essential steps to ensure that people with ME/CFS and other neurological conditions and neurodegenerative conditions receive equitable access. So for us, it's equitable access to the NDIS as well as safe and appropriate care.
Thank you very much, very comprehensive. So I'd now like to invite Limbs for Life, Ms Noonan. You've been waiting patiently online, and thank you for being with us today. Over to you.
Thank you so much. My name is Melissa Noonan. I'm the CEO of Limbs for Life. Thank you so much for having me here today. Limbs for Life was established 20 years ago, representing more than 160,000 people across Australia with limb loss. Our goal is to support people who have amputations through their journey via early intervention, peer-based support, information, education, encouragement and connections in line with the UN CRPD, Article 26, habilitation and rehabilitation. We have over 200 peer support volunteers who visit people pre and post amputation surgery in hospitals, rehabilitation centres, community, and we work to rebuild confidence and assist people on their pathway back to independent living. The impact to people from regional, rural and remote locations pre and post amputation is significant. Choice and control is important for everyone and critical for our community, but it must be informed choice and genuine control. Feedback from our consultation process suggests that this is not the case for many amputees who live in these regions, with access to the NDIS providers being very burdensome, and sometimes access to the system which requires significant amounts of reports prior to being accepted into the system. They're costly, they're onerous, and access to providers is often very difficult. To ensure the successful outcomes for people in these communities, the process to access the NDIS needs to be streamlined, straightforward, and a simplified application process with respect to the evidence of disability. More informed and confident participants, more knowledgeable and informed workforce, for example, LACs and planners providing correct and timely details. more timely interventions to reduce wait times and delays, emergency repairs for people already impacted by the reduced service provision and the tyranny of distance that they face. There are two very real and diversifying factors which stood out from our consultation. And it was regardless of literacy tools, social economic status, and sometimes, and in some cases where they live, people really struggle to navigate systems, especially if they've never used a government system previously. And that's notwithstanding the complexity of accessing service providers when we compare remote locations to metropolitan areas and outcomes. We think that the NDIS can be more responsive to people and their specific needs, and it's essential that collective knowledge with specialist organisations such as ours could be effectively used to ensure participants and workers within the system have access to independent information, product knowledge, in order to maximise their benefits. I think the other thing that's quite interesting is, with respect to choice and control, many participants will state that given it's an open market, they work really diligently to be able to seek the best financial outcome and use their money responsibly. However, quotes and invoices aren't always itemised, further reducing a participant's educational capacity about items that they're receiving and price per item. There's no recommended retail price out in that market. So even though they're in those communities, they're also burdened by the fact that they can't be responsive purchasers of equipment and services because costs and information about costs are very hard to come by. Thank you.
Thank you very much, Ms Noonan. And then finally, MS Australia, if you would like to make a short opening statement, and then we will have time for questions from committee members.
Thank you. Good morning. Thank you for the opportunity to give evidence today. My name is Katie Snell and I'm the National Policy Manager at MS Australia. MS Australia is Australia's national peak body for people affected by multiple sclerosis, and we're dedicated to advocacy, communications, education and funding and coordinating MS research as part of a worldwide effort to end MS. There's currently 33,300 Australians living with MS, and 75% of these are women. And approximately 1/3 of people living with MS are NDIS recipients. We also have a number of state and territory MS member organisations who provide frontline services and including NDIS funded supports for people living with MS. So in our submission to the committee, we drew on both feedback from these member organisations, but also people living with MS, and we do this through our lived experience expert panel, which are a diverse group of people living across Australia with MS. Also, on a personal note, I drew on my experience of living and working in the Northern Territory for 6 years, managing and delivering age and disability services in remote and very remote Aboriginal communities. So people living with MS have reported that accessing and navigating the NDIS is a complex, time-consuming and exhausting process. It's further exacerbated in rural and remote locations where there is a lack of information, supports and skilled NDIS staff. The major issue that people with MS face, and this was touched on a little bit by Anne as well, is a lack of understanding within the NDIA of progressive degenerative neurological conditions such as MS. So it's a lack of understanding around what we might refer to as invisible symptoms such as fatigue, pain, brain fog, memory issues, poor mental health and heat and cold sensitivity. Also a lack of understanding that MS does not follow a straight linear path and people might have periods of relapse and recovery. Other issues that we find people face in rural and remote locations is access to reports and assessments from specialists, a very transient health and NDIA workforce and staffing shortages, accessing any kind of supports outside business hours or weekends, long travel times to access services, and of course the additional financial burden of living with a disability. For our member organisations that deliver NDIS services, they are currently providing many hours of unfunded advocacy and support coordination to clients, especially more in those rural and remote areas, and in most instances they're running their NDIS services at a loss, and also they are covering a major gap in the cost of travel, especially when delivering any kind of therapy or allied health supports. Thank you.
Well, thank you very much for being here today. You have a great deal of expertise, and I'm looking forward to getting your feedback and advice on how we move forward. My question is one for everyone. Perhaps Rare Voices Australia, Ms Lawton and Ms Healy, you may wish to, you could begin. My question, you mentioned about equity of outcomes, and it was touched on by others presenting here today. What does, in the context of the people you represent, what does that, in terms of ideally, what would equity of outcome look like for the people you represent in a remote, rural, regional area? And can you give us one? I know there are so many things we could do, but is there one particularly on the top of your wish list that would assist us in terms of providing those quality services to people in regional, remote, rural areas? Big question, I know.
It is a big question. Thank you. The example I'll give you in terms of equity of outcome is the comparison of two people with a similar syndrome. One's living metropolitan, the other regional rural. And for the 1 hour of physiotherapy, for example, the metropolitan person living with a rare disease may travel 15-30 minutes to a physiotherapist to receive 1 hour of therapy. And they can return home, total turnaround time, 2 hours. They won't be fatigued. They may not have seizures en route. They may have been able to use their own transport and not rely on a regional bus network. And so, therefore, the outcome for the 60 minutes of that therapy is a realised benefit that is in terms of functional maintenance or functional improvement. For the person living regionally or remotely, they may have to travel 2, 3, 4 hours. They may have to travel overnight. They may not have the financial means for the travel, may have to take public transport. They may experience significant seizures, physical impacts, fatigue and additional burdens. By the time they receive that 1 hour of physiotherapy, the realised benefit, the actual practical outcome for them is diminished because of the exhausting cost and effort to obtain it. So when I talk about equity of outcome, it's actually realising the quality of life outcomes that therapy is intended to deliver. So the solution, and what we're contemplating is that transdisciplinary teams, so that can travel, and where the provider travel cost is not borne by the recipient. So currently the participant is carrying the risk of the diminishing rate of return of the outcome, and the participants' plan funds carry the risk because they in fact subsidise the provider travel in those cases where they need to incentivise over and above the price guide, the pricing limits and pricing arrangements. So if a provider can only claim 1 hour of travel, but we know that they will need to actually claim 2 or 3 hours, the participant needs to make that very difficult decision around using their discretionary funds around therapy and support to subsidise the provider. And if they choose not to, they're not accessing the functionally maintaining services. So the participant currently carries the majority of risk in terms of sector outcomes and participant outcomes. So the proposals are to separate provider travel completely out of plans, and that all participants, if they're entitled to 26 hours of physiotherapy, receive the 26 hours of physiotherapy funding, and that the provider travel component is managed completely separately between the agency and providers, or government more broadly, with alternative or integrated commissioning models. So the solution, again, to transdisciplinary teams, so rather than having qualifications where we have discrete occupational therapists, speech therapists and physiotherapists, is considering a whole of market reform around qualifications and skills and workforce to enable people to be able to be qualified across occupational therapy, psychology, physiotherapy, for example, to be able to travel into the regional and remote locations to be able to deliver greater value. And currently there are no courses or qualifications that provide that transdisciplinary team model. Separating out provider travel so that the participant is not carrying the financial burden, obligation and decision making for that. And also then expanding the telehealth infrastructure, which is not perfect for all people, because if you have a communication disability, an intellectual disability or vision and deaf or hearing disability, it may not be equitable in that case, but for some they are remediation factors. There's a comprehensive reforms though, and of course the foundational supports model, starting in a place-based, community-based model, is the key trigger, we think, to generate all of that transformational reform.
Well, thank you. Very comprehensive response. I think your knowledge is extensive and we appreciate your feedback. We do have a photographer here in the room. If anyone feels uncomfortable about having their photo taken, just please let the Secretariat know. It's purely just to record the day and let people know the work that we're doing. Miss Hilly, did you want to add anything?
I need to add to that.
No, it was quite comprehensive, I must say. Okay, and would anyone else, can I invite Neurological Alliance Australia? Did you want to make any further comment on that?
Sue Donaldson is here from MND New South Wales, also on behalf of the Alliance, and maybe she'd like to make a few comments.
Thank you. Would you like them specific to your question or...?
Yes. Thank you.
Can you just repeat the question?
So just basically looking at, we had a number of presenters here today talk about equity of not just access but the outcome, and what does that look like to you representing your membership and in terms of ideal and what would be the one thing you could recommend that could help us to achieve it?
Okay. I guess with supporting people with MND, if I can just briefly talk about MND, it's quite a harsh disease because it doesn't just affect mobility and posture as we think about, but it affects breathing, speech and swallowing, and communication. So a person could actually be dependent and unable to speak independently, unable to move, unable to breathe independently. So in terms of equity, we need access to equipment wherever a person lives. People will need to be able to trial complex communication equipment that doesn't rely on speech or hand function. In rural and remote areas, there may not be that equipment to trial. I agree, then there's the issue of people with MND travelling to a place of assessment. So being able to bring the therapist to the person is certainly much more functional. In a rural and remote area, there may not be a specialist disability accommodation that's available as it would be in urban areas. So we either need very prompt responses from NDIA and funding for necessary home modifications, or we need to look at accommodation options within rural and remote areas. Just the sheer amount of equipment that a person with MND might need through the course of their disease, which is usually very short, 2 to 3 years, that brings huge expense in terms of delivering equipment, servicing equipment, retrieving it, swapping it. So part of what the MND associations do is have a loan system where people use their NDIS funds to hire our equipment. When we're talking about the NDIS plans, what we need is planning that allows for those extra costs that are involved with the transport of equipment, the transport of people to their services or the therapist to them, and also to even look at the capacity to hire wheelchair accessible vehicles. We can think of a number of occasions where people, planners who don't understand the regional and remote areas will suggest that a person use a wheelchair taxi or a community bus that's wheelchair accessible. They don't exist everywhere. So it requires more funding to meet those needs, and so people can engage not just in addressing the physical, practical needs of living with a disability, but also to engage in the social and community aspects of living and to create memories in the time that they have with their family.
Yeah. Thank you very much. I was going to now invite, if Ms Noonan, you wanted to add anything to that, and then we'll just, allow you all, and then I'll open up for questions and invite Senator Sharma to speak first. Ms Noonan.
Thank you. I'd just say that I agree with the previous representatives in that it's very cost prohibitive for people to be able to access services, and sometimes they're the simplest services without supportive travelling plans and/or cost prohibitive services relating to access to therapists and/or service providers. And I think the impact of this further is that, there's extensive wait times and workforce shortages at the best of times, but this can further be exacerbated by people or for people who live in rural, regional, remote communities. So, I'm wondering if there's ways that can better facilitate access for those people to return to, a larger community in order to regain their independence. For example, if someone has a right lower limb amputation and they need to retrain for driving, they're in a community where they could wait 12 to 14 months for an appointment with an occupational therapist, and access to that therapist for driver retraining could, cost up to $3,000 in travel for that therapist to get to that individual. So, which is, that's an excessive amount. Yet, by transporting in some capacity that individual to a larger community where there might be a larger workforce, access to regaining their independence via regaining their driver's licence could be expedited in that way. So I think, it's looking at streamlined processes which are going to give, a faster turnaround and a better outcome for those people impacted by, in my case, limb loss.
Okay, thank you very much. I mean, obviously the transport and the cost of transport is very important to all people who live in remote communities with disability. Ms Snell, did you want to add anything?
Yeah, I just wanted to jump onto what Fiona mentioned about that idea about separating out the cost of travel. I'm very conscious that we're trying to cap costs in the NDIS, but yes. I do think in remote regions we should explore a model where providers could actually be paid the exact cost of travel. So because in some regions it can be so expensive and so far beyond what pricing is, or it can be really different depending on circumstances or what mode of transport they use, I think we should have some more flexibility. And I think you could use something like the modified Monash model as those barriers, perhaps in regions 5 to 7, for example, you're a bit more flexible with the costs, because I just think there's such a huge difference in the costs, and you're never going to be able to come to a costing that exactly matches.
I suppose the challenge is the economy of scale, in a sense, like how do we ensure that we're getting that value for money? How do we ensure that, like, if you've got a number of people in one community with a particular disability, or even with a range of disabilities, to have that expertise coming to a regional remote area in nearly like a one-stop shop, so that we actually make it efficient but also effective. That might come back to what you were saying, Ms Lawton, about a model where you bring people together and they go out as a team. Is that what you were suggesting?
Yes, so if I may expand on that. So yes, a multidisciplinary team, but with a broader, knowledge and skill based, which is quite purposeful and intentionally supported by government in terms of qualifications, because it actually represents a significant value for money. But the second thing is the integrated and alternative commissioning model. So we hear from people living in regional, rural, remote, particularly if you live with a rare disease, you may have complex bowel care needs which directly impact your daily toileting requirements, feeding and dysphagia management. You may have daily intensive disability-related health support needs. Your neighbour down the road, maybe a long road in a rural area, but your neighbour down the road is receiving similar supports from a nurse that's funded from an aged care or a DVA support model. That nurse is actually attending that community, but because that nurse is not funded for a disability participant, the NDIS participant goes without that support. We're reliant on the carers becoming the provider of last resort in these communities because there are no hospitals or alternative places, yet the nurse is attending the community. So the integrated alternative commissioning model, which really does take a concerted effort from state and the federal government to identify who is in that community and where we can get those economies of scale and those efficiencies, is probably the simplest approach and probably the first that I would consider, particularly for those complex daily support needs that people with rare disease have.
Well, thank you. And I'd like to thank you, Senator Sharma, and others for your patience. It's over to you now.
Oh, it's quite all right. Thank you. I just had a question for the Neurological Alliance Australia. Hello, good morning. Just interest of mine, is FND, functional neurological disease, is that covered by your peak organisation, Neurological Alliance Australia? I didn't read it here.
It is, but there isn't a specific organisation for FND. But yes, I mean,
okay.
Yeah.
I thought there was one called FND Australia, but perhaps I'm wrong. I just wanted to check if it was covered because I've heard being contacted by individuals with FND talking about. I think the main challenge they face in accessing the NDIS is their condition is seen as transient rather than permanent.
And that is with so many of the neurological diseases. They're categorised as a disability and therefore they are excluded. And, no more so than people with MECFS who are just really often denied access. And when I'm talking about denied access, we have examples of people from all over Australia who they have so many hurdles put before them in order to be able to get considered. They need a functional assessment from an occupational therapist. Well, for a lot of these people, whether they've got MECFS or other functional neurological disorders, that costs a lot of money and they don't have the money for a functional assessment. The letters of support from clinicians are disregarded. It's not unusual for us to hear from patients who have waited 2 or 3 years for a response, and in the meantime their condition has got worse, they've become bedbound and they literally have no support. And there is a lot of stigma for people with functional neurological disorders. They're just not believed because their conditions can be so transient. So they might be able to muster up the energy on one day and on another day they will crash for days, weeks or months. And that's where an understanding by the assessors of their condition, an understanding of the defining diagnosis around post-exertional malaise, which is something where people can crash if they don't manage their energy levels properly, is just not taken into consideration. And that's where the knowledge of assessors is critical to this patient cohort. And I would endorse, the comments of other colleagues here about the need for, multidisciplinary teams. I think that's critical for rural and regional and remote Australia. Our people don't even get to see a GP in their local, regional and remote area who knows anything about MECFS, let alone have allied health support to be able to help them, A, get their application in, and B, be able to get the allied health support that they need in the management of their day-to-day lives. It's a huge issue, and people, and I speak passionately on behalf of my patient group right now, they are so stigmatised, they are so disbelieved that they actually aren't sick, that it is really, it's almost a human rights issue.
Okay.
And it needs to be recognised as such.
Thanks, Ms Wilson. And I just had a question about, I think, your recommendation in the submission. So I think you have it as a recommendation too that the government accept the NDIS review recommendation for eligibility to be based on functional impairment rather than medical diagnosis. Can you just, I'm relatively new to the scheme, I'm happy to admit, so can you just explain to me why that's important and why you've advocated for that?
Functional impairment recognises the various conditions that people have that are invisible, that are not classified as a disease. But these are all we represent. The Neurological Alliance represents people with neurological disease, neurodegenerative disease. These are diseases that affect the functional management of day-to-day life. And they're just not recognised in the same way as other diseases are. And some of those diseases are also represented by Rare Voices Australia. They're small diseases, small groups of people. Often they haven't had a voice to advocate on their behalf. People with MECFS, yes, we've got 250,000 people in Australia with MECFS, many not diagnosed. And we've got about 40,000 clinicians across Australia, very sparsely located in rural, regional, remote Australia, who can't even diagnose these patients because they don't know how. So this is a very disadvantaged group of patients, and they have not been well treated by the NDIS. We've got some dreadful stories, and we now have people, and I won't read everything out, I'll give it to the people when I leave, comments from people with lived experience where they've had to move from their homes in rural and remote Australia in order to be closer to a place where they can be diagnosed, closer to a place where they might be able to get a functional assessment, uproot their lives, the isolation that these people experience as a result of having virtually lost their ability to live in society, especially for those who are bedbound and housebound, and they represent 25% of the 250,000. They are just isolated, and no more so than living in a rural, regional and remote area of Australia.
Okay. And
just add to that about the diagnosis. There are about 7,000 rare diseases and counting, more being discovered all the time as genetic medicine and genomic medicine improves. And so with a focus on diagnosis, you close out a whole lot of, unless you want a list of 7,000 rare diseases that are associated with the disability, and then the list becomes unmanageable. If you focus on the functional impacts, then you're really addressing where the quality of life issues are rather than the diagnosis.
Chair, if I may, a practical example, if I may. So my son is diagnosed with Angelman syndrome. He's also diagnosed with Simpson-Galabi-Bamel syndrome. He's diagnosed with epilepsy, sleep onset and maintenance disorder, sensory processing disorder. He's met NDIS access only on Angelman syndrome because there's insufficient evidence currently of the functional impact, apparently, of the other rare diseases that he has and other complexity. So a functional impact assessment doesn't require us to have a matrix of symptomatology and functional impacts against each condition, but considers a person-centred, holistic approach of what are the challenges in terms of getting out of bed, feeding himself, dressing himself, etc. So it becomes diagnosis agnostic, and starts to look at those actual day-to-day functional impacts. And so we certainly, on behalf of Red Voices Australia, we also support that recommendation.
Okay, thank you.
Can I
Ms.
just
Snell,
add, within the MS cohort, there's quite a diversity of disability, and a lot of that can be affected by when you get a diagnosis of MS and how early in that process you get access to disease-modifying therapies. So the longer it takes, the more lesions you'll get on your brain. The heart, there's no recovery from that. So that can be more complicated. People who have been diagnosed more recently are less likely to have complex disability. So there's really no one set case of this person has MS and these would be their symptoms. It really is a case-by-case basis.
Can I just ask about that? I noticed that I think in your submission you mentioned there's about 33,000 sufferers of MS in Australia, but only about 10,000 are on the NDIS. Is that a function of the age profile of the cohort, or what's it a function of?
It's a combination thing. Some people aged out of the NDIS, so by the time their disability is complex enough that they need support, so they're already in that aged care group. It's also an improvement in disease-modifying therapies with MS. So today...
So people who might not actually need to access the NDIS, but okay.
If you got diagnosis today in your 20s, early in your disease progress, and got access to therapies, you can have much better outcomes.
Mm-hmm.
We're not quite sure, what that means for those people in 30 or 40 years' time, but significantly improved outcomes for MS treatments in the last 20 years. So obviously most people here, when I mention MS, think of people in a wheelchair and dying quite young. That's not the outcome for people today.
Mm-hmm.
And also I think we find in the MS community people tend not to access supports until they really get to that critical stage.
Right, okay.
And it's because of things like those what we call invisible symptoms. People feel, they don't know how to get support for that. So it's not till perhaps they get a physical relapse that they'll go and access something like the NDIS.
Okay, thank you. And then just one last question, if I could, Chair, to Ms Noonan online for Limbs for Life. I have to remember what my question was. Oh, sorry, we'll come back to... I'll remember what the question was, so I've jumped around all the submissions. So back to you, Chair.
We'll come back to you.
If that's all right, thank you. Yeah.
Senator Urquhart.
Great, thanks very much. Thanks everyone for appearing. I just wondered if each of the organisations could let me know if you have that information. If you don't, if you're able to go away and provide it. How many participants does your organisation support in rural, remote and regional areas compared to metropolitan areas? And do you have that broken down into the different numbers of the modified Monash models?
I can speak. Right now I couldn't
Fantastic.
provide it, but I would be able to.
Okay.
I could try and get it too.
Yeah, yes. I don't want you all to go away and spend enormous amounts of time doing research, but if you have that, I'd be really interested, because obviously this inquiry that we're holding is focused on rural, remote and regional and the NDIS and accessibility. So we're trying to really drill down into, that sort of thing. So if you are able to provide that on notice, I would appreciate that. And I think, Ms Snell, you covered it really well in your opening statement, and that was about the experiences of the participants that the organisations here have as your clients. But can you tell me, I'd like the other groups if they can, and Ms Snell, of course, if you've got anything to add, about the experience of your participants and your clients accessing services and supports in rural, remote and regional areas. So, Ms Lawton, I think you've given us a little snapshot, but maybe if you've got anything else to add and then we can move around, I'm really happy for that to occur.
So,
and sorry to jump in. I guess if you could order this is probably going to be really difficult, because I know it's different for lots of different diseases and conditions, but if it's possible to give it in a sort of a priority type order, that would be really helpful.
So the challenges, people with rare disease typically will need assistance with daily living supports. So the most fundamental self-care right through to the community access, etc. So the current experiences are extremely thin markets. quite a high transient casualised workforce, and because of the level of complexity, we've got a workforce capability gap. So we certainly are advocating for micro-credentialing around things like the complex bowel care and the dysphagia management, etc., as incentives to progress that workforce capability issue. But extremely thin markets. So we're finding that the carers are those providers of last resort in regional, rural, remote. Yeah. We've talked about therapies. We certainly know the tyranny of distance around therapies. But things like continence aid delivery. So you may not even have the ability to have your continence aids delivered to your door. Yeah. You may still need to travel or pay for an intermediary to transport your continence aids from the local town for an hour or two. Yeah. And again, the participant is carrying that financial risk because the uplift is not occurring in their planned funds to compensate for those delivery costs. So they're making the decision between accessing paying for some in-home support versus paying the delivery costs for their continence aids. So I think it's summarised in that the most fundamental and basic needs are struggling to be met and go unmet because of that reason, in addition then to accessing the therapies, etc. Plus then the review cycles are intensive around evidence because it is an insurance scheme. So the ability to engage with your GP or your specialist service in a timely way to gather the evidence that's needed to justify ongoing or in many cases increasing support needs is extremely problematic. And so that actually exacerbates and elongates the time where you have you're being under-supported or under-serviced as well too.
Yeah, okay, thank you.
I'd just like to add, we get a lot of feedback from people with MS that their local area coordinator has a big impact on them accessing services. So already, a number of people touched on the poor quality of NDIS staff and their training, and we're finding in those regional and rural areas the lacks are even, poorer in terms of their training. And that's the sort of person that they rely on to say, what services can I get, where can I go, where can I get them? And if they can't give them any information, that's really limiting their ability to go out and get those services in the first place.
So it's the knowledge of what's available within that area.
Or even what they, when they're sort of sitting down to do planning, they're like, well, I'm not really sure what I can access or what sort of support's available. They're new into this NDIS space. That's who they're relying on. A lot of people, if they live in cities, they can join peer support groups, they can meet other people. That's not happening so much in those other areas. So the lack is that's their one contact to the NDIS.
Yeah, okay, thank you.
Thank you. Touching on that, I guess MND associations, our staff will do pre-planning with anyone that's registered with us to help them prepare for the NDIS, because we need to think about function right now, but also because of the rapid nature of MND, we need to expect functional decrease in the next 6 to 12 months. So that's very important.
So
with
it's
any
time critical, really.
It's time critical to get access, and then it's also important to so we don't have ongoing reviews, which are stressful and costly in terms of therapies, the therapist doing reports and the coordinator gathering everything, to be thinking for all of neurological conditions that are progressive, that there may be a progression, a decrease in function, and therefore to allow that in the plan. Touching on, to date, there hasn't been regular reviews or check-ins with people, so they get a rollover plan. Parts of their funding will be taken away. There's an assumption that because they've had AT funding, assistive technology funding, their needs have been met, but because they have functional change, they need new and different equipment. So,
Ms Donaldson, could I just very
yes.
quickly ask,
yes.
on your observation, how does that, you talked about the training preparation, but also the time critical nature of getting supports. How does that vary between, say, metropolitan to a rural, remote and regional community?
Well, fortunately, our staff will go out to regional places, but we can't go out frequently, so we might have to rely on technology.
So there would be some
definitely differences.
Yeah.
And if you're looking for specific therapeutic recommendations from OTs, physios, speech pathologists, respiratory physios, you need to have those therapists in the area, and as we've discussed, they're just not necessarily there, and they don't necessarily have had the experience with MND, so we need the ongoing education, and again, bringing participants to therapists or bringing the therapist to them and looking at all of those costs.
Yeah. Great, thank you.
And sorry, may I just touch on,
Sure.
I agree that people with MND at some points will need 24-hour care, and so we need caring staff that know how to address all the higher needs, how to help people with peg feeds, how to help them with cough assist machines and non-invasive ventilation and toileting and all of those things. So we need to train the workforce much harder in a community. And an example I have in Braidwood, which is not that far from Canberra, I could not get a service to come from Canberra or Queanbeyan to provide in-home services for a person with MND. It was only because a local nurse in Braidwood established her own company that he was able to stay at home and have services in his home.
Okay.
And that's not too far.
It's not too far, no, that's right. But very difficult for someone with a disease such as MND, but extremely difficult,
and worse in more remote areas.
Absolutely, yeah. Miss Wilson, and then I'll go to Miss Noonan, and then I'm happy to hand the call.
Sure. I'd just like to add what Sue said, and that is that where you've got conditions like MND that can progress very quickly, there's probably also a need to be able to shorten the process, the whole assessment process, because the time that it takes the NDIS to do anything is often very out of step with the progression of some of these diseases, which really needs to be considered. In answer to your question, and I've put a priority order down, but I do want to read what one of our members of our community has written. And she said when the LAC did home visits and could access the environment, it was something they could more easily appreciate. But when it's not face-to-face, I'm talking to a brick wall and there's no care or concern for my welfare and using my NDIS funds fully.
So that face-to-face is very important rather than on the phone or whatever.
That's right, because being able to see what's going on and how functionally impaired people are is a real challenge if, etc., doing remotely. So what are the things that our people need? They certainly need help with self-care, and they certainly need social work support, and that is at the preliminary stages when they're trying to apply for the NDIS. They just don't have the energy, and the energy is often cognitive energy to read a form, understand it, and then being able to fill it out. So we're right at the beginning of access, and that is even worse for people in regional remote Australia who they're socially isolated. They just don't have the people that can help them. So obviously home help is a huge area that people need assistance with, and because it's not age discriminatory, so we're not talking about someone who's an older person. You know, we've got young people who were at university and have had to give up their studies. We've got a whole database of GPs who are bedbound with MECFS. We're talking about a very non-discriminatory disease that affects the ability of people to function.
Okay.
Obviously, transport to appointments, access to services and carer support.
I'm sorry, we are very tight. Miss Noonan, do you have anything to very quickly add? Because I'm conscious that I've stolen a lot of time.
No.
Not at all. Primarily accessing the system. So someone with an upper limb amputation, for example, they're missing their arm, need to have a functional capacity assessment prior to being accepted into the NDIS, even though that disability is visible. Not something that can be done by a GP, so excessive wait times, and that funding or cost for that, which can be between, say, $800 and over $3,000 to have that assessment done, needs to be paid up front prior to accessing the NDIS. Number two, once they're in, complex assistive technology, which is what we all use as amputees or people with limb loss, access to trialling that equipment before a final decision has been made, because often prior to a plan approval, someone has got to trial up to 3 pieces of equipment prior to approval.
Yes.
So the length and the delays in time for doing that.
Great. Thank you, everyone.
Thank you very
That's
much.
really
I'd just like to acknowledge Ms Payne has joined us. Welcome. And over to you, and thank you for your patience.
That's right. Look, I'm very aware that we're short of time, and I'm going to sort of probably be the most controversial one here, because I have experience of living rural and remote, and I have experience of a child with an NDIS participant and a disability. And I'm a little bit concerned, Ms Lawton, with some of the things that you've said, because we are currently, as an NDIS participant's mother, very worried about the sustainability of the scheme. We are more concerned than anybody else, because we need it there for our kids when we're not. That there's because we're short of time, I'm going to have to be a little bit blunter than I probably would have. But living somewhere that's only accessible by boat whilst requiring complex care needs, there's an element of choice there versus what the taxpayer should be required to fund. And I'm sorry that's a little bit blunter than I probably would have liked to have been. I think we have to be really careful how we talk about the scheme and equality of access versus equality of outcome. I understood very, very well, living 80 kilometres west of Moree, which isn't a big centre in itself, 10-hour drive from Sydney, that there were pros and cons with living that lifestyle and that location versus ultimately a move to Sydney because we needed to access proper educational supports, et cetera, that just weren't available. They're just never going to be available because of, you did mention economies of scale. So how do we start to have a conversation that accepts that if you do want to live in a particularly remote area or a rural area, there are additional challenges, but that's not always needing to be borne at the cost of to the taxpayer.
And very good points. And I agree that there's an element of choice there for sure. I think as a community, as a society, when we start to just separate out the disability impacts from broader life choices around quality of life, around well-being, we don't consider the housing crisis in metropolitan areas, cost of living crisis, etc. So if we look at just the NDIS costs associated with supporting someone living in regional, rural, remote, and if that's just treated in isolation, the cost-benefit analysis might be challenging to stack up. But a whole of social impact cost and aspects around social prescribing and alternative non-medicalised, non-therapeutic approaches to living with a disability should be considered. So a whole of person-centred approach is, I guess, what I'm saying. So people are moving to regional locations because of the cost of living crisis, because of the housing crisis, because of employment issues. They're moving and seeking alternative living arrangements because of the complexities. They're moving closer to families because they are providers of last resort. So I think it is a holistic approach, and that's why I'm really, on a personal level, but also on behalf of RVA, really strongly advocating for that entire foundational support reform to consider from the ground up at local council level, at state government, at federal government, and at the familial level. What does a holistic, person-centred, family-centred, place-based model of support look like? And just treating the disability element on its own, I think, is an artificial approach to that.
Yeah, but at the end of the day, the NDIS is for people with permanent and lifelong disability. And I guess one of my other concerns with some of the comments that have been made across different areas, the NDIS doesn't, for anybody, pay for diagnosis to access. It doesn't matter what you've got, you know, it doesn't pay for that. But a lot of the things that seem to be being referred to are medical, as opposed to permanent and lifelong disability. So one of the things the NDIS also doesn't fund is things that should be provided by other services. And it's not just you, I'm not just picking on you guys, but there's quite often an expectation that the NDIS will pay for everything, or that the NDIS somehow needs to be responsible across the board. And this is why we're in an awful state, because the state governments have vacated the field when it comes to a lot of the community health aspects and a lot of those things that they used to do.
So, Senator,
is there an overuse of the NDIS for stuff that should be medicalised?
If I could just say something about that. I think that from a individual perspective, the line between medical and disability is a artificial line, so it's really hard to draw those lines, and what we see is that overlap and that area of interface is really quite a challenge for most people who have a medical condition associated with a disability. It is a really challenging, and what it should do is integrate, but what it does is create gaps, and I think this is where the foundational supports opportunity is there to look more holistically at all of the services that are provided and take a whole of government approach to these things, so there is an overlap, because we are very, like you, sustainability is, I agree, a huge issue, and we can all see it looming as a problem. But I think that if we took a whole of government approach in a coordinated way that allowed more case management type arrangements, you wouldn't have overlap and you wouldn't have gaps. But at the moment, you either have overlaps or you have gaps. And so it's not working in either way. So
we may have to leave it here just due to our
just
time
any
frame.
of those comments that I made, and I know some of them probably were a bit blunt, but if you want to respond on notice, I'm more than happy to take a look at them.
Yeah, and if we could put the focus on regional, remote, rural, because that is what this inquiry is about. But, I mean, sustainability is very important, and I think that's why our government is currently looking at bringing the states and territories back on board in terms of providing foundation services. And what I think is very good is that the Minister has worked with the states and territories, and there is an agreement. So now it's about what we do, how we roll it out, and how we bring the states and territories back on board to provide those services, which are really important, particularly with early intervention, but also for people that may have more complex and diseases or disabilities that are going to shorten lifespan, and we need to do everything we can. So, on that note, I would like to thank you all for your time. It's very valuable, the contribution you make, and it will help us to form recommendations that we will then advocate for to government to do better in this space. And you're at the coalface, and we do thank you for the work you do. Thank you. We will now take a break, and we will return at 10:45. Thank you. So thank you very much. We are now going to reconvene and I would like to welcome representatives from National Disability Services who are joining us by video conference, and Speech Pathology Australia, who are in the room with us today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. And just before we go further, I just wanted to ask the committee, we have received a document from Neurological Alliance Australia, and just to agree that we can table that document.
Sure.
Great, thank you. So now what I'd like to do is welcome you and ask representatives of National Disability Services if you'd like to make a short statement. And I should just say I do have Senator Hughes and Ms Payne with me, and there will be a number of other committee members coming to join us shortly. So firstly, over to National Disability Services to introduce yourselves and make a short statement.
Thank you. And can you hear me okay?
Yes.
Thank you. Good morning. My name is Emily Forrest. I'm Deputy CEO at National Disability Services, and thank you for the Joint Standing Committee for meeting with us. I'm going to discuss very briefly the current state of the disability services sector, and then I'm going to hand over to Ben to talk specifically about disaster management and how that affects services. NDIS, National Disability Services, is the peak body for service organisations, and our members provide services for people with all types of disability. We have a very diverse membership, right from very small organisations through to large multi-state organisations, and collectively they employ around 100,000 workers and support approximately 500,000 people with disability. As the peak body, we're deeply concerned about the ability of service providers to continue offering quality supports to participants, particularly in regional, rural and remote areas of Australia. So thank you for taking the time to meet with us today. The current state of the disability services sector presents some really significant challenges that we think threatens the sustainability of services in these regions. We do a yearly survey at NDIS. It's called our State of the Disability Sector Report, and we do that in partnership with the University of Sydney Centre for Disability Research and Policy. And our most recent report shows some very concerning trends. We have 69% of providers concerned that they can't sustain services and are worried about their financial viability. And more than 50% were reported making a loss or just breaking even last year. Despite these very serious and ongoing financial difficulties, demand for services continues to grow. 82% of our providers had requests for services they couldn't fulfil due to things like staff shortages, a lack of resources, or a lack of suitable staff. For our regional, rural and remote providers, we hear about long waiting lists, particularly for people trying to access services like early childhood intervention services and allied health services, but it is also across the board. Recruiting qualified workers is a huge challenge, especially in allied health like OT, psychologists, behaviour support practitioners and speech therapy. However, even roles in other parts of the organisation are increasingly hard to fill. Management, IT, finance and HR, and it's in part due to that strong competition with other parts of the economy. These combined financial and workforce challenges create what we're calling a perfect storm for providers, particularly in regional, rural and remote areas. And trying to meet the complex needs of participants in these regions is becoming increasingly difficult when providers are struggling just to find qualified staff and operate within a deeply unsustainable funding model. We also do a workforce census each year, and we've done one since we made the submission to the committee, so we have some new data there. Our latest workforce census shows that there's a very high reliance on casual staff, with 37% of the workforce characterised as such. And this creates instability, as casual staff, as you'll know, are prone to higher turnover. I think in the last year alone, we had almost a quarter of casual staff turning over within a year, which is creating this constant churn and making it very difficult to deliver consistent, high-quality care. It's also incredibly expensive. We have conservative estimates of the cost of staff turnover based on modelling from the Australian Services Union, which puts the cost of onboarding new staff from between 80 to 190 million for the sector each year. And this is an unfunded cost borne by those organisations delivering services.
Can I just ask, sorry to interrupt,
Yes.
Ms Forrest, it is an opening statement and there will be opportunity to raise those points. Is there anything, and they are valid points to make, but in relation to regional, remote, rural, which is the focus of this inquiry, is there anything specifically as a general statement you wanted to make before you hand over to your colleague as part of a short opening statement?
I might hand over to Ben then, because Ben's going to cover some of the specifics on disaster management.
Yep. Thank you. Please go ahead.
There's always one person who struggles to get off mute. Good morning. Thank you. Can everyone hear me?
Yes, we can.
Excellent. So I'm Ben. I'm the CEO of ARC Disability Services. So ARC is Cairns' local not-for-profit organisation who has supported people with disabilities and their families and stakeholders since 1976. Personally, I've been with the organisation since 2002, and ARC is a registered NDIS provider. We're a not-for-profit charity, and an easy way to describe our scope of services is everything but therapy and supported employment. I will summarise what we were going to talk about today, but essentially what we're looking at is compounding challenges during disasters. So when you're in a rural and remote area, and we're often more prone to quite significant disasters, the workforce limitations are phenomenal in trying to ensure that we meet our obligations under the quality and safeguard standards to our participants under their disaster preparedness. Infrastructure costs is an issue. There is limited, if any, availability around getting participants who have complex care needs into cyclone shelters or support areas when they are isolated or if they have challenges to their support. If a cyclone is coming or a disaster is happening and someone requires specific support at a specific time, for example, we support someone who requires specific medication assistance. If they have quite complex seizures, we need to be able to manage that somehow. There are huge communication and coordination gaps and inconsistencies around expectations. Once you start going to more remote geographical areas, the infrastructure doesn't even allow for consistent communication. So if you're someone who's deaf or hard of hearing and you rely on a text messaging service, that service might actually not be available to you. In terms of improvements, we would like to see a national plan for disaster inclusive preparedness, a nationally consistent one throughout all levels of governments. That will work to address the workforce and capability within the sector. It should include targeted training and funding for programs to incentivise professionals to go out to those regions, because quite often that will be the first area that professionals will cut if they can't get there. The other one is also around supporting a disaster payment scheme for NDIS providers. Because we have an obligation of continuity of services during emergencies, the scheme needs to acknowledge the increasing costs that are associated with maintaining staffing levels, particularly during these times of high intensity support requirements. Financial assistance like a disaster payment can help providers cover expenses like overtime or staff working extended hours if they've been, for example, flooded in with participants, but you can't neglect participants and prevent preparing care. So collectively, we need to work towards a more inclusive disaster management framework that safeguards everyone, all NDIS participants living in rural and remote areas. So very grateful to be here today, so thank you.
Yeah, well, thank you for that, for all that information. Very succinctly put. Thank you. We'll come back to questions, but before we do so, I'd like to invite Speech Pathology Australia to introduce yourselves and give an introductory statement.
Thank you. I'm Jodie Long. I'm the CEO of Speech Pathology Australia, and I'm here with my colleague Erin West, who's our Senior Policy Officer. And I would like to thank you for the opportunity today to be able to provide some evidence. Speech Pathology Australia is the national peak body for speech pathologists, and we represent over 15,000 speech pathologists across Australia. Speech pathologists are university qualified allied health professionals who provide really vital supports for NDIS participants who have communication and swallowing needs. These quality therapeutic services are really deeply meaningful for the functional participation of people with disability in everyday life. But we are facing a workforce crisis. We've got an ever-thinning market in the rural and regional and remote areas. NDIS participants in these areas aren't always able to access speech pathology supports that they require. Waiting times for services are higher than metropolitan areas, and a third of NDIS providers working in the rural, regional and remote areas indicate that there is a wait list of more than 6 months. Some rural and remote towns don't have speech pathologists in their town, and service users must travel in excess of 2 hours to access these critical support. 84% of providers in these areas indicated that travel was a significant issue. Unfortunately, these difficulties are not currently acknowledged by NDIA, as providers are not supported to provide services in these areas and cannot continue to absorb the business costs, particularly with regards to travel. Participants in rural, regional and remote areas do not receive additional travel in their plans, which effectively really does discriminate against them. Additional access to additional travel funding may be the difference then between accessing services and not. The most recent NDIA quarterly report, reflecting the 12 months to the end of March 2024, shows that participants are actually not spending their therapy budgets. Participants in states and territories are spending perhaps up to 60% of their budgets for capacity building and daily activity. In Tasmania and Northern Territory, they're spending less than half of their funding that's been allocated to their therapy services. It is critical that a specific workforce strategy be considered to support NDIS providers in rural, regional and remote areas. The particular needs of participants in these areas must be addressed, including greater wraparound and support services, and definitely looking at travel funding in plans. Access to necessary supports for participants should not be a postcode lottery and limited to only those who live in metropolitan areas.
Well, thank you very much. Did you want to add anything, Ms. West?
No, we've kept it brief to our opening statement, so we'll wait for questions.
Thank you very much.
Look, done this before.
It's been consistent with the presenters today that there's been a discussion or a focus on a shortage in the workforce into regional, remote, rural communities. What do you think is the answer? If I can ask, firstly, Speech Pathology Australia, and then go to National Disability Services. Have you got any thoughts about how do we address this issue? Because it's substantial, I understand that.
I'll take this one. So we actually included some suggestions in our submission, and it's several levels. So this is not a one-size-fits-all. This is not a silver bullet situation. This is something where there needs to be consideration of multiple factors. So it's support for universities to establish programs in rural and regional areas, which means that students who wish to actually study to become these support workers, or in our case speech pathologists, are actually able to stay in their communities.
Yep.
And that they would also have priority of access, because my understanding is some of the regional universities are actually international students are being given those places. Then we would also have support for students to link in with housing if they are attending placements in rural areas or remote areas. We've heard about placement poverty. There's been a bit of discussion around that. Talking about linking in with housing that's been established for the public health workforce, actually for the NDIS workforce potentially. And then incentives for rural, regional and remote practitioners to actually take on students to help to train that next generation, so that they are understanding the types of participants they're going to be working with, the type of case that they're going to be working with, the particular challenges of that area. And then it means that we know that if they're on a placement, they're more likely to actually potentially then know what they're moving to and then be more willing to actually take a placement, a work placement in those areas. Extension of existing allied health scholarship opportunities to include some disability-specific services and organisations, and also extension of certain programs that are often only open to general practitioners to include allied health, but also I know there's some programs that include some allied health, so for instance it might just be OTs. I believe social workers have just gained additional access to a particular program to incentivise them for their placements. It's making sure that that's across the board so that the shortages of allied health are actually being addressed by these programs.
Well, thank you. Look, that is actually quite comprehensive. You've obviously done a little bit of homework before you got here, so well done. Can I just ask you before I hand over to National Disability Services, speech pathology, it is quite crucial, particularly in early intervention. Can I ask you, have you got any sense of what the need is and what the gap is in the number of qualified speech pathologists in rural regional areas?
I can touch on that a little bit. It is difficult for us to gather that type of data, so I might start with that. The reason for that is that speech pathologists are self-regulated, so we're not under APRA, so we don't have very good national data with regards to even our own workforce, because self-regulation is associated with funding and it's voluntary if you're not doing it from a funding perspective. I might hand over to Erin to complete that, but that's a concern for us, is that we have an inability to access national data.
Yeah,
thank you.
So a lot of the workforce data that is gathered is based upon APRA registration, and so that makes it challenging for self-regulated professions. The other issue is that sometimes it's based upon the ANZCO code, if you're familiar with that. It's a number that's kind of associated with particular professions. It's assigned by the ABS, and we have not had our own code basically since it started. That's been investigated now, and there's a proposal for us to have our own code, which will hopefully come in December.
It's nice to be recognised.
Yes.
All right.
And then the other issue is that in terms of the exact number of it's really hard to say, because we don't even have necessarily good indications of the needs of those participants potentially in those areas, in terms of, are we capturing all of them? Are we capturing everything that they need? Or are we just allocating them certain things that we think that they might want to access? So we do know that a lot of participants do require access to speech pathology, but we couldn't tell you how many versus how many are actually out there with exact numbers.
It's interesting because data is so important when you're trying to get an understanding of what the issues are and how to tackle them. Thank you.
We did our own workforce analysis in 2021, and we did see thin markets across Australia.
Yes.
But it's not divided specifically by areas. Yeah.
Well, thank you very much. Now, before I hand over to National Disability Services, I'd just like to acknowledge that Senator Urquhart and Senator Sharma have just joined us. Did you now want to, if I invite Ms Forrest and Mr Keast, did you want to add anything to that?
Yes, I would say really support what Jodie and Erin have outlined and agree about the need for a workforce strategy. I'd probably add to that, there's a few things in addition we could think about. One of them being programs like connector programs and promoting careers in the sector within these areas. So connecting people from school and TAFE and universities and promoting a career in the sector. That's something that's not been done very well or holistically around Australia. The other thing I'd say is there's a funding issue underpinning all of this. One being that the cost model that currently all these providers are relying on doesn't adequately fund the sorts of services we're talking about. So we've been talking about the need for there to be more independent pricing of services, and that includes things like unbundling the cost of therapy into what is the cost of speech pathology, what is the cost of speech pathology in a regional or very remote area. It's quite different than talking about, for example, personal support or even potentially psychology or something else. That doesn't exist at the moment, and it's a real problem. The other problem with the funding model is it doesn't adequately fund training and supervision. So again, that goes to that question of why would you work in the sector? It's hard to get good training, it's hard to get good supervision, the pay could be improved. So again, we're losing workers to other sectors when we're not making it more attractive for people. On the question of pay, we've also said there needs to be a review of the industrial agreement that underpins a lot of the sector, which is the SHADS award. It's not fit for purpose at the moment. It's complex. It doesn't align with the price guide set down by the NDIA, and it's very hard for providers to use that to attract new workers into the sector. I'll probably hand over to you, Ben, to talk about things like worker screening, because that's another one I think we should talk about.
Yeah, thank you, Emily. So one of the challenges in quite rural and remote areas is around the worker screening and people's ability. Sometimes it is something as simple as to provide 100 points of ID to be able to go through the worker screening process is a barrier. There are the issues with regards to competitiveness within remote areas. People quite often will operate in an unregistered space and not necessarily have the quality or the understanding of the services that they're delivering with. Sometimes people make bad choices early on in life, which prevent them from getting screenings into the future, and that could actually be balanced sometimes with risk mitigation strategies and risk assessments rather than just a straight no, which creates a block. In rural and remote areas, quite often when we have the stand around family can't support family, and I'm not advocating we should start going down that path entirely, but we do need to look at that because quite often family is mob, and once you go mob supporting mob, that then becomes a barrier because lots of people do have relations in communities, and so then that does restrict the workforce. So as part of that workforce plan, we really need to consider what remote service delivery looks like and how we can work within the local communities to make sure that we meet the demand in a safe and risk-assessed way.
Thank you. I mean, some valuable feedback on how do we actually get people out on the ground with expertise into regional remote communities. Thank you. I'd like to hand over to Senator Hughes now.
Thank you, Chair. And I've just got a couple of sort of quick questions really for the speech therapy or speech pathology Australia. Community health, we know a lot of community health workers went into the NDIS or private practice because of how it was being set up. There's talk around the current bill with changes to the NDIA and the NDIS going back to the states to provide foundational supports. No one actually knows what they look like because that's not drafted yet. Does any state still have a community health system in place that could substantially step into that gap quickly?
I don't know that we are the right people because that would be dependent on what they had available with their services. I would say at the moment, what we're hearing from rural areas, particularly I know in Victoria, is that their community health services have shut their books and that they actually, some of them have been kind of contracted, and they were previously providing perhaps therapy services and now they're providing planning services or linkage services under NDIS. This is what has been reported.
Yeah. Because community health is quite often the only services in rural and regional areas because there aren't private providers. So what I want to sort of know, if tomorrow we pass the NDIS bill and it goes to foundational supports that the states are supposed to provide, how are rural and regional communities going to be impacted? So in Victoria, a lot.
That is what we've heard reported, is that they have closed their lists, and it was a 1.5 year wait before it was closed. This is old
You're kind of
information,
missing
to
the
be
critical
fair.
developmental delay window if you're a
Correct.
1.5 year off accessing a
Correct.
speech therapy service.
Correct. But we don't necessarily have good data because it's not shared with us, because we're a peak body and they are often
they're state
funded.
Yeah. Okay.
So, yes.
That's okay. We just did discuss the importance of hearing from the state governments and how ready they are going to be.
And the actual health services themselves, because they would have the best data about if they've got hiring freezes, if they have a large portion of unfilled positions. We do know there is an issue with pay parity in New South Wales compared to other states. So it would be remiss if we didn't mention that, because that does affect
So
people.
they get paid more or they get paid less?
They get paid less.
Wow,
And
most
so-
expensive state and they get paid less.
Correct.
Well done.
Again, that's what we're hearing reported, and it means that people are less likely to move there. Particularly if you're talking about border communities, so like in Tweed Heads, you can just go work in Queensland and get paid quite significantly higher.
Wow, okay. I know we're sort of running a bit tight. So how many placement hours does a speech pathology student need to do? And is it in their 4th year?
It depends on the program. We might have to take that on notice.
Okay, if you could just give us an, because we do know that the placement can be quite onerous. I met with OT Australia last week and they were saying around 1,000 hours in the 4th year. So just sort of to get a bit of a sense of what the placement hours required are, but also what the requirements are for them, because, is there a way to get more creative that placement hours can be done maybe working as a junior with a child that's... So because my next question is sort of having... There's no point to speech therapy, and again I'm focusing on that developmental delay, early intervention side. There's no point going to a speech therapy session if you don't read the Mr McGee book 25 times a day when you get home during the week, or you don't practice the sound or whatever it is.
Senator Hughes, question.
Well, this goes to the crux of it, because a lot of people are paying for a speech therapist to fix their child without doing the in-home part. Do you work with your speech pathologists, or is there something behind that to either focus, provide the data, work with the families that are doing it, and sort of be realistic with the families that aren't, that there's no point using the speech therapy if you're not going to do the exercises at home?
Can I just also remind everyone that we are here for a regional remote rural inquiry and putting it in that context, which is, it's a very important question. But just, obviously, whatever...
It doesn't matter where you are accessing it, but in rural and regional it's harder to get an appointment. But if you've got appointments being taken up by families who aren't doing the work versus those that are.
So if you'd like to answer the question.
I might do the first bit, which was about the hours. And I'll just mention that we have just recently re-looked at more competency-based rather than hours, and we can get back to you on that. But that is absolutely something that we've just re-looked at. So to your point, to help try and support the fact that it's not as onerous.
I believe, if I've understood the question correctly, you're wanting to know, do we have specific programs that encourage speech pathologists to develop the skills of parents?
Well, that's what speech therapy sessions are.
Yes.
But obviously you get some parents that go home and read the book 25 times a day and practice the sounds, and then you've got some that just don't. And if it's hard enough to get into someone, and we've got workforce shortages, is there some way that we can prioritise, track data? Because it's throwing good money after bad if people aren't doing the work at home.
I would say that we as a peak body don't collect that sort of data. It may be that individual providers might, but that's also sort of a value judgment that they may not be making about their clients. It may be that they provide the same service and they are providing a lot of additional support to those families to try and build their capacity.
Okay, I'll pass it on. But
Thank you. Ms Payne.
Thank you very much, both organisations, for joining us today. My question is to both of you, but I might start with speech pathology. In your experience, are there particular challenges faced by Aboriginal and Torres Strait Islander participants? And on the flip side of that, are there particular challenges for you in delivering supports in rural and remote areas for First Nations people?
There are, in particular, particularly around building the trust and the rapport. That's a crucial element with the Aboriginal and Torres Strait Islander peoples. And I might hand over to Erin to elaborate.
So just acknowledging that we are white people. We don't come from an Aboriginal or Torres Strait Islander background, and we're reporting on data from our members who work with Aboriginal and Torres Strait Islander peoples in these areas, but they may not be from those backgrounds either. So just to acknowledge that that's just from their perspective. So what we've definitely heard is a much higher need for time. So that appointments take a lot longer because there is yarning, there is a need to, you don't dive straight in. You have sort of time to kind of set the scene, set the context of what's happening for the family, all those sorts of things. And so we've got a quote actually in our submission around somebody saying, it's an hour appointment and it's perhaps schedules an hour appointment, but for an Aboriginal family, you might need to schedule 75 minutes to 90 minutes because you need to allow for that time because that is culturally responsive practice. Another issue is around a kind of attendance, for lack of a better term, in the sense of it is a system, a health system that is not necessarily set up to be acknowledging an Aboriginal way of being and doing. And so you have a set time that you are going to turn up and you need that family to be there at that time, at that place. And that might not necessarily happen. And so there is potentially a need to link in with, say, your Aboriginal controlled organisation to make sure that everyone's on board with making sure that appointment happens. And so again, we've had reports of sort of somebody going to a home to have a visit, and they had a great relationship with the family, but they still wouldn't come out, and they had to go and get the Aboriginal worker to go in to then actually get the family to come out.
Right. Okay, thank you. I might go to NDIS if you could respond to that question as well around challenges both for First Nations participants to access, but also your ability to deliver services in the context of rural and remote communities.
Yeah, to add to what Erin and Jodie have said, again, I'm not an Aboriginal or Torres Strait Islander. We do have members who provide services specifically for First Nations communities, and their issues in regional, remote and rural areas are the same as issues elsewhere, but exacerbated, which is they're struggling to maintain their services based on the funding they get to deliver those services, because there are lots of things that are unfunded that they're having to meet. And it's becoming less and less sustainable year on year to try and meet that demand. The other problem I think that would be interesting for the committee to look into, but it might be more a question for the NDIA later in the day, is the very high rates of underutilisation of participants' plans and also the low take-up plans for First Nations people, despite the fact that we know that disability affects that population quite highly. So that's a big issue, and obviously points to a huge amount of unmet demand in those communities that is just simply not being met, which is a real concern. The NDIS review made a recommendation as well on the need to do alternative commissioning of services in thin markets where there is, less service delivery, and First Nations communities is one of those, and talking about how First Nations people should be partners in determining what that alternative commissioning looks like. And there'd be lots of different ways of doing it and models for doing it. But from an allied health perspective, for example, looking at what the plans need to be in those areas, what the gaps are, what the underutilisation is, and then working with different service providers to come in and deliver that service in a sustainable way for that community. And we need to see that done really quickly. And I think is an also really clear example of where there's a strong role for the states and territories to be working with the Commonwealth on that project.
Thank you.
Can I jump in on that as well? Sorry.
Please.
So a lot of the time the support that happens in rural and remote, particularly rural and remote Indigenous communities, is one provider might build up a body of work, sweep in and do, for example, a body of functional assessments and then sweep out again, but there's no continuity or follow-up for the individuals within those communities. So it does talk to the importance of that direct commissioning or alternative commissioning around how do you support that community and then upskill from within the community. There are huge barriers for our First Nations people to integrate with the NDIS because there is a bureaucracy that comes with having an NDIS package in itself, which, again, I'm not an Aboriginal or Torres Strait Islander person myself, and I struggle with it. So we, as a service provider, we have to make allowances about the fact that there are going to be many services and supports that we provide that actually is whole of family supports rather than individual supports, and that is unfunded, but you have to do that to be able to build up trust and relationship to be able to then support the family to then look at how you can best support them into the future and develop sustainable supports. And sometimes families request mob to support them, and sometimes actually families request not mob to support them because it's their own business and they don't want to share it. So you have to be able to be agile in that space.
Mm-hmm. Thanks, Mr. Keast. And that actually is a good segue into my next question, which was, given the particular needs that you've mentioned, does the NDIS as a, structurally, does it support you being able to deliver those supports? Like, for example, going to the example that Ms. West mentioned around needing a longer appointment, is that something that in the current NDIS structures that you're able to deliver? Happy to go to you first, Mr. Keast, if you wanted to respond.
I would suggest possibly not. Once you go, this is NDI, like the market stewardship is the price guide. The price guide then has very strict constraints around what you can build for and what you can't. And if you look at the current rhetoric, heaven help you build for something that you shouldn't. But realistically, you can't build for relationship building. You can't build for family supports because the NDIS is solely focused on the individual. There is no reflection in the NDIS around what does sorry business look like and how does that apply to a person who receives services? How can someone from an Aboriginal or Torres Strait Islander community return to community? Is there any allowance for that? And that's sometimes the barrier to that is actually their disability. Because I know of one person who we support who lives in Cairns because this is where she was able to get supports, but her community is Thursday Island. So trying to get supports to go back home and connect back with community and family, and how does that fit with the NDI pricing? It doesn't. So quite often, who's left to pick it up is the organisation, or it's just unfunded and it doesn't happen.
Mm-hmm. Thank you.
I would say that, yes, that's the report from our speech pathologists as well, is that they are providing a lot of these soft supports, these wraparound supports, these essential risk supports to enable culturally safe practice, and it is unfunded and they are absorbing these costs themselves. And that is particularly around in early childhood. It's not just Aboriginal and Torres Strait Islander communities, but particularly around early childhood, because there is unfortunately a significant traumatic history around trust in services, understandably, and you need to work very hard to counteract that. And so we have a report from a member who had to go I believe it was 3 times to a playgroup for more than an hour, unfunded, and that was to be able to engage with this particular family from an Aboriginal background. And it was on the 3rd visit that they disclosed that, oh, I thought you were from welfare. They wouldn't talk to them until then because they were so concerned.
Right. Yeah. Right. Thank you for that. I'll leave it there. Thanks,
Thank
Chair.
you. And I should acknowledge that we have Dr. Ryan has joined us. And over to you, Senator Shah.
I might go for questions
You're okay?
given the time. And
all right, okay. Do you have
obviously
any
a few
questions, Senator Carter?
No, I'm fine, thank you.
Dr. Ryan? Yeah. Okay. So no further questions?
Could we potentially add something? Actually, just I know we're short on time. We'll be brief.
In relation to regional remote?
Yes, yes. So it's around the attraction of workers that Ms. Forrest brought up.
Yep.
So as part of our workforce review that we did, we actually saw that students are more likely, like what actually attracts them to a role is that good support, that supervision and training, and that is currently not funded by the NDIA. So that has to be provided completely at a business expense to that organisation. And that is something that possibly may make a difference if there was better funding or even any funding and support for those kind of programs to be available. And the other thing is just on business cost with the price is that 40%, and this is from our members who are in rural, regional and remote areas, said that it doesn't, they charge at the price that they are allowed to with the NDIS price guide, and it doesn't cover the cost of service.
Okay. Well, thank you. It's very good feedback. And we thank you all very much for your time today. It is very valuable the information you've provided, and hopefully it'll help us to create recommendations that get to the crux of how we better support people in regional, remote, rural areas. Thank you.
Thank you.
So we will just take a brief suspension while we wait for our next presenters to come. Thank you. I'd like to welcome you to this inquiry and thank you for your attendance. With me today I have Senator Sharma, Senator mental break, Hughes, my apologies, Senator Urquhart, Dr Ryan and Ms Payne, and myself, Libby Coke, the Chair. I'd like to welcome you, representatives from Australian Psychosocial Disability Collective, Tandem, who are joining us by video conference, as well as the National Mental Health Consumer and Carer Forum and Lived Experience Australia, who are in the room with us. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate committees has been provided to you. And for the Hansard record, if you could please state your name and the capacity in which you appear today. And how, if we could just perhaps begin with the Australian Psychosocial Disability Collective. I think you may be muted as you're online.
Hello. Sorry, I'm finding this whole thing really stressful. I need to read from my notes. My name is Kristen Gillespie. I'm a disabled woman and carer living in a rural part of Victoria. I'm grateful for the support of my NDIS key worker who is with me today. I'm a member of the Australian Psychosocial Disability Collective. We're a grassroots lived experience advocacy group campaigning to protect the rights of people with psychosocial disability in the context of NDIS. All of us, apart from our convener, are psychosocial participants of the NDIS. I acknowledge the Wurundjeri people of the Kulin Nation as the rightful custodians of the stolen land where I am today. I pay my respects to elders past, present and emerging. I recognise their connection to the land and waters and their ongoing role in caring for and maintaining country over thousands of years. I also acknowledge any Torres and Aboriginal and Torres Strait Islander people listening today. For me, transitioning to and dealing with NDIS has been a nightmare in many ways, as it is not a trauma-informed approach, but it has been deeply life-changing. I've had support that I never had before, which I desperately needed. I've had access to capacity building support, which has in part helped me navigate managing the support I have and coping with people in my own home. I probably wouldn't be alive today without it. For months, I have been desperately trying to speak out about the harms of the current public discourse around the NDIS review and now the bill. This has caused me a huge amount of distress and also physical pain. I cannot raise my left arm fully anymore, and it's painful if I try. What does raising your hand signify? Asking for help, being seen. As a child, it was often unsafe for me to be seen, and help seeking was punished in my family. Yet I keep putting up my hand to speak out as if my life depends on it, because it literally does. This bill is an existential threat for many of us, not merely because it's change is definitely needed, but because it's extremely complex and harmful change with erosion of PWD's rights to agency in our own lives at its heart. People with psychosocial disabilities on the NDIS are amongst some of the most vulnerable people in this country. We are generally, in my experience, from interacting with my peers, survivors of a significant trauma, often multiple types of significant trauma across our lifetimes. A quote from Brené Brown on grief research. Disenfranchised grief is a less studied form of grief that is not openly acknowledged or publicly supported through mourning practices or rituals because the experience is not valued or counted by others as a loss. The grief can also be invisible or hard to see by others. Examples of disenfranchised grief include loss of a parent or partner due to divorce, loss of an unborn child and or infertility, the multitude of losses experienced by a survivor of sexual assault and loss of a loved one to suicide. I have experienced all four of these, as well as numerous other kinds of trauma. As an illustrative example of disenfranchised grief, Tashel Cordair, the researcher, explains that sexual assault survivors suffer from numerous losses, many of which are invisible to others. Some of these losses include loss of one's prior worldview, loss of trust, loss of self-identity and self-esteem, loss of freedom and independence, loss of a sense of safety and security, and loss of sexual interest. This deeply resonates with my experiences. As survivors, we are also vulnerable to further trauma. Many of us have to work incredibly hard just to live and try to function at all. Some of us need to find and use strategies and reasons to keep living every single day. Multiple marginalisation is common, and we frequently face stigma, discrimination and abuse. This occurs within our communities, it occurs in the media, it occurs in politics. Sometimes it even occurs in the disability community, when the public discourse not only invites but also encourages lateral violence, like now. We're frequently portrayed as too disabled to speak on our own behalf, and therefore are spoken over by people who are not us, like providers, whilst simultaneously portrayed as not being disabled enough for the NDIS. Neither of these things are true. With suitable accessibility and support, we can speak on our own behalf. Many of us are significantly, severely or profoundly impacted by our disability on a daily basis. These things affect us across the country, in cities and beyond. Many of us who live in rural and regional and remote areas face additional marginalisation and are even more vulnerable because of the increased isolation and lack of access to safe and appropriate support locally. We face thin markets, and many of us rely on independent support workers to provide specialised supports. One example is we are much more at risk of being impacted by natural disasters due to climate change, such as bushfire or flood. We may also experience difficulties leaving in an emergency, be unable to leave on our own, or have nowhere safe enough to go if we do leave. I'm privileged to be white, so I cannot speak on behalf of all or Indigenous experiences, but I can only imagine the enormous additional difficulties they face being further marginalised. I hope that they too might be empowered to speak in this place. Thank you.
Thank you very much, Ms Gillespie, for that moving opening statement, and we'll come back and speak to you further about how we actually improve services to you, but thank you very much, and yeah, wishing you all the very best. Ms Smithen, did you want to add anything to that opening statement? It's not necessary, it's just if you wish to.
So there'll be more time to speak down?
Yes, absolutely. Okay, thank you very much. I'd like to hand over now to the National Mental Health Consumer and Carer Forum.
Thank you. Would you like us to provide our opening statements now in addition to stating our names for the Hansard record?
Yes, go ahead.
Awesome. So my name is Jordan Frith, and I'm here today as the Deputy Consumer Co-Chair of the National Mental Health Consumer Carer Forum.
And Ebenezer Swan for the NMHCCF and Senior Policy and Project Officer.
Thank you.
Awesome. So we're speaking today in relation to our submission to this inquiry from the forum. So the forum is a national representative voice for people with a lived experience of mental health challenges, their families, carers and kin. We're also a disability representative organisation for people with psychosocial disability. Every person on the forum is a person with lived experience, either as a consumer or a carer, and we'll use the term consumers and carers in our opening statement, although acknowledging that there is a diversity of opinions on how people would choose to identify and label their lived experience. We've made a submission to this inquiry to highlight the significant discrepancies in service accessibility, health equity and opportunities for NDIS participants in regional, rural and remote areas. People with psychosocial disability who are NDIS participants in metropolitan areas already experience significantly increased barriers to accessing NDIS services compared to the general disability community or people with other types of disabilities accessing the NDIS. And these barriers are incredibly exacerbated the further out from a metropolitan hub that you go. Every single element of engaging with the NDIS, from the initial application, attempting to acquire evidence, searching for supports, retaining quality supports, accessing safeguarding mechanisms, all the way through to transitioning between areas, locations, levels of support, types of support and different support services, carries an additional difficulty and cost for people in rural and remote areas. The forum has heard from our members and from consumers and carers in a variety of different settings, including rural and remote areas, that there have been increased experiences of stigma and discrimination attempting to access the NDIS, both from NDIS providers themselves and from the communities that they are accessing these services in. Significant difficulties accessing support due to transport and internet access disadvantages, difficulty interpreting and applying for the NDIS due to difficulty accessing online services, local area coordinators, and acquiring the right form of evidence. And there is limited to no choice and control over the services that they receive. There's significantly reduced access to specialist disability supports, which is essential for people with a psychosocial disability, in addition to pre-existing gaps in the mainstream mental health services in these communities, which contributes to worse health and wellbeing outcomes for people with lived experience. As such, the Forum strongly recommends that every stage of every change in the NDIS implementation embeds a process of co-design with people with a lived experience of psychosocial disability and their families, carers and kin. Consumers and carers in these communities deserve targeted, place-based co-design processes in their own communities, by their own communities, to ensure that changes improve, not erode, existing support access. The Forum further recommends that this committee collaborate with and hear the unique needs of First Nations people with a psychosocial disability in a way that supports the self-determination of these communities to define their own needs. We hope that this committee can support a nationally consistent, lived experience-led approach to reimagining the NDIS service system for people living in hard-to-reach communities. And we're happy to take any questions on specific elements of our submission as well.
Okay, thank you. Mr Swan, did you have anything to add?
No, that was...
Thank you very much. And then I'd like to hand over now to Lived Experience Australia. If you could introduce yourself and give your brief opening statement.
Thank you. My name's Sharon Lawn and I'm the Executive Director for Lived Experience Australia. I'm also a member of the National Mental Health Consumer Carer Forum and it's lovely to see colleagues here today. I was born and spent all of my childhood and adolescence in a rural Victorian region, Sunraysia. I maintain strong links with rural communities in my personal and my working life. My spouse receives a small NDIS package, so it's very much in my realm. Lived Experience Australia is a national representative organisation for Australian mental health consumers and carers, using that title again, family, care and kin. We were formed in 2002 with particular focus on the private sector but broadly across systemic advocacy. Our friends include more than 7,000 people across the country with lived experience of mental health and psychosocial disability. Our network of friends includes many people living in regional, rural and remote locations across Australia, including people currently receiving NDIS, people navigating eligibility, or people who have unmet needs related to psychosocial disability in particular. We represent a disproportionate number of people in rural areas. For example, when we reach out nationally with surveys, we invariably get 30 to 40% of people that identify as coming from rural areas when they respond. I think that's because of unmet need and the need for advocacy. Within the short time frame that we had for this submission, 15 people came forward from across the country in rural areas. In our submission, you'll see one of those people gave quite a detailed case example, which I included at the end. They had direct experience of rural, regional and remote Australia experience, and they provided their perspectives to you. So we welcome the opportunity to appear before the Senate hearing today, particularly to give you what they told us. So we heard many comments about the challenges all across the stages of the NDIS process for people in rural areas. The tyranny of distance doesn't have to be restated. A core problem with thin markets has already been mentioned, or no markets at all. of providers available to adequately serve the needs, even when a plan is approved, which then impacts the quality and accountability of service delivery. So coupled with core challenges in rural areas such as distance, greater levels of disadvantage, this then serves to undermine the core aspirations of choice and control that underpin NDIS. For example, I've just returned from the SA Riverland region where I met with people there who were on the NDIS. They have among the highest disadvantaged population in the state of South Australia, where I heard about the disproportionately high number of NDIS recipients on administrative orders, which I found really quite concerning, and how this adversely impacts them. So they have the double issue of choice and control issues, but then also an administrator sitting in an urban environment administering their funds and choices of what they're actually receiving. So the issue of thin markets also is an issue for privacy and confidentiality, which is quite different in rural areas to urban areas. There's more choice of NDIS workers and services and anonymity. The relationship between community members are different in rural areas. I'd certainly know that growing up where everyone knows everyone. Service providers work and live in communities where they serve. There are problems with the quality of planners and delegates, often located in urban areas, is what we heard from people, and others like public trustees serving rural communities, and a clear gap in their understanding of the differing needs and circumstances because they just don't live in rural areas. The ability to travel, the weather, the road conditions, many things that they just don't even think about in urban areas when they're talking to people on the phone in rural areas. Rural family carers disproportionately pick up the tab repeatedly because of systems that just keep failing rural people, yet they're unacknowledged for their role. People reportedly struggle to action the plans and spend the money that was allocated to them on their plans due to a lack of available services to deliver the required supports. They also raise concerns about structural inequity in how transport and travel is accounted for in rural areas, with the 1 hour provided for travel when people may live on farms, they may live out 2-3 hours distance from the local centre. There was concern also raised that some are getting no service or settling for online options, and that was an incredibly big issue that the Renmark people also emphasised. They're sick and tired of just thinking that telehealth is going to fix everything. We know the importance of face-to-face support for people with psychosocial disability, especially for building trust and working with individuals who've experienced trauma. Incredibly important. There's less availability and access to quality training and supervision for staff in rural areas. Lived experience workforces in particular are less able to access the Cert 4 in mental health peer work, for example. Quality placements as part of that, and less likely to receive Commonwealth supported access to this qualification than their urban counterparts. There's less supervision, less peer support among peers, less community to practice quality access, so that you have a skilled workforce delivering NDIS. Health professionals providing core supports may be fly-in, fly-out workers predominantly who just don't live in those communities, that don't have a commitment to those communities, and they're applying metropolitan understandings. So there are trust issues as well there. The issue of thin markets issue again is also an issue with open and transparent feedback. If there are problems with the service provided it significantly hampers rural communities. It's quite unique. No one living in rural communities wants to lose services. There's a greater risk of poorer service to go unchecked simply because any service is better than no service. Community relationships can be more complex when services or infrastructure are actually fundraised by the local communities themselves, and reporting issues with the staffing, etc., are actually problematic because that service can simply close and it can create ill will and conflict within communities. It impacts unemployment, the very viability of a rural community. There are challenges with short-term funding contracts in rural communities for NDIS providers, many who have their central administration and main workforces in metropolitan capital cities. The workforce is often tenuous and people moving between roles and jobs. It creates significant challenges with recruiting, retaining, training workforces for rural areas. Overall, they just get a raw deal, really.
We may need to wrap it up shortly because I want time for members to ask questions, and we still have Tandem to introduce.
And my last comment is that the experience of discrimination, prejudice and racism potentially have historical underpinnings for some rural communities which need to be factored in as well.
Thank you very much for your presentation. I'd now invite Sarah Irving from Tandem to give her opening remarks, and if you'd like to introduce the other members of your team that are online.
Thank you. Yes, Sarah Irving here, Manager Policy and Advocacy from Tandem, also joined by Amaya Alvarez, Manager Research, and Joanna Pankhurst, Senior Policy and Project Officer. I'm filling in for Tandem CEO Marie Pugh, who unfortunately has lost her voice. So Tandem is the Victorian peak body representing the needs and interests of family carers and supporters of people with mental health challenges. The Tandem membership consists of almost 3,000 individual family carer supporter members and 112 organisational members. Tandem is also the Victorian representative on the National Peak Mental Health Carers Australia. We thank the Standing Committee for inviting us to appear today. I'd like to acknowledge I'm joining you from the lands of the Boonwurrung people, and this always was and always will be Aboriginal land. I'd like to pay respect to their elders, past, present and emerging, and to extend this to any Aboriginal and Torres Strait Islander people who are present at the hearing today. Tandem's submission drew upon 105 survey responses from family carers and supporters of people with psychosocial disability in regional and rural Victoria, as well as drawing upon the extensive experience of staff providing family carer peer support on Tandem's support and referral line, who report that 58% of total calls are where the NDIS is the presenting issue. The experiences of family carers and supporters that Tandem hears strongly echo the NDIS review's findings about the many shortfalls in relation to psychosocial disability support and across the scheme more broadly. People with psychosocial disability in regional and rural areas, as well as their families, carers and supporters, have markedly poorer health and wellbeing outcomes than in the general population. The fundamental causes of the disparity are systemic and structural. By way of example of how these disadvantages can compound, we know that insufficient service provision, both within and outside the NDIS, can lead to family members having to give up employment to attempt to fill the gap, leading to severe financial hardship. Nearly a quarter of regional and rural respondents to a Tandem survey reported that their caring role meant that they couldn't study or work at all, and an additional fifth couldn't study or work full-time. Tandem members report the impact of the housing crisis and income support payments below the Henderson poverty line being particularly dire in regional and rural areas. Psychosocial disability support, both within and outside the NDIS, needs to include a focus on relational recovery and family inclusive practice as part of reform efforts to improve quality. Working with people with severe and persistent mental health challenges is specialised work and as such requires specialised knowledge and skills. The deprofessionalisation of the psychosocial disability workforce must be urgently addressed. In our submission, we quoted the following from the NDIS review. A good life is one enriched by connections to family, friends and community. These connections need to be nurtured by the scheme. This means individualised, market-based delivery needs to be balanced with approaches that build social capital. Achieving this balance through genuine collaboration and partnership with lived experience must be a strong priority within disability reform if we are to improve health outcomes for people with psychosocial disability and those that care and support them in regional and rural remote areas. Thank you.
Well, thank you very much. And I understand that there are some representatives here who have not spoken yet, but I do think in the course of the discussion that you'd be very welcome to add your remarks. But just due to time frame, what I'd like to do is go straight to Dr. Ryan to ask her questions.
Thank you, Chair, and thank you to all of you for your testimony, which is really powerful. I might actually start with you, Ms Irving, if I may. You said that deprofessionalism needs review. And I guess one of the issues that we hear very consistently is the issue of thin markets in rural and regional settings. So would I be right in saying that your concern is that care is being provided by people who don't have appropriate professional skills in rural and regional settings? Yeah.
Thank you for that question. Yes, so just reflecting on what we heard, that is correct. So reflecting on what we heard from the family and carers who completed our survey that informed this submission, and what we hear from families and carers who contact the Tandem Support and Referral Line, those experiences are of a lack of quality providers delivering quality psychosocial supports and unskilled support workers. As one survey respondent said, unskilled support workers doing specialised work. So, for example, and this is just one example, a family carer talked about how the participant, their son, took days to recover following an interaction with a worker who had a background as a gardener, but who didn't have the skills and capabilities to know how to appropriately respond when the participant was in distress and thereby causing more distress. And that's just one example. So family carers talked about their experiences of not being able to access psychosocial recovery workers or behaviour supports in the regional and rural areas, and having support workers come in to provide support, but without those skills, without trauma-informed approach, understanding of mental health and psychosocial disability. That came through quite strongly from the family carers that we spoke to.
Thank you. Ms Frith, I'm guessing you would agree with Ms Irving. Would that be fair to say, that this is an issue, that the carers are being funded by the NDIS but perhaps don't necessarily have the professional training that would be optimal for them to provide best practice care?
I think it is absolutely essential that people with disability are matched with workers who have the necessary skills, particularly for an incredibly stigmatised and marginalised community, and that carers do disproportionately take up the burden of when that fails. So 100% agree. I would maybe just add that the professionalisation and non-professionalisation of the support workforce can be quite a complex issue, particularly when we're looking at extreme lack of availability of any services in regional and remote areas. So I believe the forum generally would advocate that lived experience workforces in particular that are based and developed and trained in the communities they're working in would be a good approach. And that support is also available to carers as well, who matching with people who understand their specific needs.
That's actually exactly the point I was trying to get to. So I think there is a bit of a balance here, because we want people to be able to very often we hear about the importance of having people providing care who do have lived experience and an understanding of the challenges that NDIS recipients and other individuals are experiencing. So would you, given these issues with thin markets, which no one argues are a really significant problem, and the answer to that is not to shop people in from the cities who are going to stay there on short-term contracts and then go home again, would it be your premise that we should improve training and support facilities within rural and regional centres for people who are providing these sorts of care?
Excuse me, could I speak to this question as well, please?
Sure.
Yep, no problem. Go.
Should we go to Ms. Frith first and then to...
Yes.
I'll be very quick. Yes, absolutely, people should be trained, supported and working in the communities that they are supporting. Understanding for remote communities this can be difficult, but it is a responsibility, I believe, for this committee to consider how we could still develop mechanisms and infrastructure that will support that.
Ms. Smith then?
Yes, so I wanted to say that I disagree with Tandem, Ms Irving, as I am an NDIS participant with psychosocial disability and autism, and I've had schizoaffective disorder for 18 years since I was 27. So I have used a lot of services over the last 18 years. So I have a pretty good idea of what the services are like. For psychosocial support workers, they've always been a very low qualification area. If you're in hospital, you see mental health nurses, and the nurses have a university degree. And psychosocial workers maybe have a TAFE, like prior to NDIS, the psychosocial workers maybe had a TAFE qualification. Sometimes you get one who is a social worker or something, but often they don't have very high level qualifications to begin with. And the thing is that what we saw in the past is that the psychosocial workers would often refuse to do things that we wanted them to do. So they'd refuse to help us do our dishes, they'd refuse to help us clean, they'd refuse to help us do gardening. What they often like to do is go out for a cup of coffee. So they might like to help us go shopping to a shopping mall too. So, and if you go to an actual, someone who is a provider, I used to use providers, now I use unregistered workers, but the providers often have rules about what they can and can't do too. So when you're actually thinking about this, think about what were those qualifications, or what are those qualifications? Are they good quality qualifications? What are they teaching people to do? And then think about what are the workers with those qualifications going to be doing with this, with participants? Are they going to be listening to what we want them to do? Or are they going to say, we're a psychosocial worker, we don't help with the dishes, because that's what we have so often helped before. And I can tell you, I have psychotic episodes with relative frequency, and someone doing my dishes when I have a psychotic episode is really helpful. So also in terms of recovery work, I would say my personal experience is with the recovery work that providers do. For the first 10 years of having schizoaffective disorder, the recovery work could be really helpful. But after I'd already done it repeatedly for 10 years, it stopped being that helpful. I can just remember what I already did in previous recovery work with people. So that's another thing. What value-added things are they giving to us, and how does that change for the longer that we have our disability or mental illness? Because when we're not all like just in those first 5 years of having a severe mental illness or psychosocial disability, some of us have had it for 10, 20, 30, 40 years. So, I do disagree. I've got some really great workers who don't have qualifications, and have had ones who are good with qualifications too, but the qualifications are not the thing that makes the difference. It's really the personality and values of the worker that usually makes the difference, in my opinion. Thank you.
I just add for the minutes that I can see Ms Gillespie nodding furiously.
Can
I just
briefly to that?
Yes, go ahead.
Can I just add to that?
Sure.
I I support two family members or to navigate on.
Sorry to interrupt. If you could just introduce yourself, because we haven't...
Oh, sorry.
Yep.
Yes. My name's Amaya Alvarez and I work as a research manager at Tandem.
Thank you.
And I both agree and disagree with Zoe. So from my experience with support workers, but also I feel like it's an issue of the design of the NDIS to a certain extent. Psychosocial disability has always been seen as something that's about the psychosocial and not about capacity to do physical stuff. And it's taken me a long time to work with support workers who recognise that simply because someone has arms that work, that doesn't mean they can necessarily manage sort of everyday physical stuff. So I don't think that's necessarily an issue of, I think that's a kind of a, blame the workforce, or not blame the workforce, but I don't think the problem necessarily lies in the way in which the workforce approaches people with psychosocial disability. It's partly about the way in which the NDIS has created that division between physical disability and psychosocial disability. So if you have physical disability, it's recognised that you need physical supports. If you have psychosocial disability, you need social interactions and all those things. And I think that's kind of a space that's infused. And both of those things are what's required in support workers. The other thing I think with support workers is that need for, I guess they get, that whole idea of, well, how do you, if you're in that workspace, do you look for sort of professional support or networks of support? Do you look for training and skills, and who's allowing you or providing that? So there's both the notion of unskilled in that space, which I think is problematic because they're not always unskilled, but also what do we look at for supporting this workforce in these communities and building those networks of practice and skills that can mean that they stay in the work for longer because they feel like they're kind of getting a sense of it. They sometimes require those skills to navigate high levels of stress, and sometimes that's not something that is required. So it is very much, as Zoe said, on an individual basis. But that sense of having those skills in case something happens can be really important around your sense of your own safety, but also the safety of the person that you're supporting in that space. So
thank you.
Yeah.
I just want to say that probably in regional remote communities, the issue of the appropriate getting person who is trained is quite challenging at times as well. And I think the challenge for us is we can go into different there's lots of different challenges here, but if we can just remember that we're doing this in the context of rural, remote, regional, because that's where we're really focused on what can we do in those communities, particularly understanding that it is quite a challenge. I think, Ms Gillespie, have you got your hand up there? Did you want to make a comment?
Yes, please. Thank you. I just want to second what Zoe said. I hear what Amaya is saying. Look, if I could suggest that there is one piece of training, or maybe two, that would be enormously beneficial, because frankly, a lot of the cert stuff from TAFEs is hugely problematic, and sometimes fosters unhelpful perspectives on psychosocial disability or disability generally. And those two things would be that we support and enable workers who want to work in this space, and I don't just mean for people working with psychosocial disability, but particularly for people with psychosocial disability, is firstly the trauma-informed training that Blue Knot offer, which includes the Power, Threat and Meaning framework, which is incredibly important to understand in the context of working with people with psychosocial disability, and I would argue important in working with anyone with disability, given the extent of trauma experienced within the broader disability community as well. And the other one, in terms of care work, would be intentional peer support, which is a much more nuanced and kind of relationally based training, and something that I've really benefited from having my key worker who did intentional peer support. It's really been hugely helpful. And I would also say that I don't think that the heart of this is training. I really don't. The heart of this is actually the agency of the people who are receiving the support. And I know this is really complicated, but, you know, personally, it is far more important to me as a disabled woman that I have support workers who are respectful, who listen to me, who actually do what I ask them and trust that I'm asking them to do something because I need it. Amaya touched on the issue about people not understanding the difference between capacity and capability. I am very capable of cooking. I've been cooking since I was 9 years old and I'm now 60, but I often do not have the capacity because my disability is so exhausting. And, you know, adding to it that I'm also a full-time carer, I suffer from chronic burnout. And that's even when I'm, you know, relatively well, which for me is chronically depressed, just not severely enough to be suicidal. That's my well. So, you know, I think we really need to be clear about this. We also need to be clear that, you know, I'm sorry, in my experience, this is not an NDIS problem, this issue about not understanding the difference between capacity and capability. This goes way back and is very pervasive within the community mental health sector. You know, I've had workers tell me in the past with the very limited support that I had that, no, we can't help you with that. We only do with, we don't do for. And, you know, this is a really ableist and paternalistic notion that they know what we need done for us or with us. You know, my current workers take the view that if I've asked them to do something and I happen to be actually home, then they're doing it with me, and that I'm asking them to do it for me because I don't have the capacity at the minute. You know, I'm fiercely independent. I don't like having to have help, but I bloody need it. And, you know, so I ask for help for things that I actually need. And it's given that help seeking was punished in my family, it is incredibly difficult and painful to ask for help. And when people who think they know better tell me that I'm capable of doing this, it is incredibly triggering. Thank you.
Yeah. Thanks very much, Ms Gillespie. Did you want to have any more questions, Dr. Ryan?
No, I think it's just a comment, if I could. I think we're actually all coming at things from the same position, which is that we want a workforce which is better able to support the people in rural and regional centres. And what we're just talking about is how best to do that. And I think everyone's saying that they need the workforce to be better trained and, well, to be better able to be more supportive of people who need that support. And the question is just how best to do that.
Can I pick up on the issue of agency? Because what I know in the rural areas where the people have spoken to me is that there may only be 2 support workers and they're so-and-so's granddaughter or someone's cousin. Yeah. They're meant to come for 2 hours. They skip off an hour later. You can't complain because there is no other worker that you can then do another option in a rural area.
Yeah, well, thank you for that.
That's the issue here.
Yeah, it is a good point, and I can see some head nodding there online. Yeah. I'm just wanting to get as many questions in the mix as I can. Senator Urquhart?
Yeah, look, just following on from that, I live in a rural area, regional area of Tasmania, northwest Tasmania, and I travel down to very remote places, so I see the sorts of issues that we're talking about here and the lack of services. I guess I'd like to hear from people on the panel here today around what sort of suggestions. I think because we have the complexities of the different diagnoses that are covered on the NDIS, they all, and we've heard, you know, I think a smattering of it today, that there are lots of different requirements from individuals about the types of support. We have got thin markets, we've got lack of training. How do we overcome that, the lack of training, the thin markets? Obviously, you know, if we can get more people in. I know that a lot of people are resistant to having fly-in, fly-out, but how do we capture within a rural and regional remote community someone who is prepared to say, I want to be a carer, I want to be a worker to support people on the NDIS? How do we train them in all the different complexities of what each individual person needs? It's a really big question, I know, but I don't know if there is an answer to it, but I'd be really interested to hear your thoughts.
I think, can I go on? Yeah. I think they don't need to be trained in understanding diagnoses, because
great.
that's a very clinical lens, and I'm getting nods. They know their local community, they know the families, they know the landscape of how the community and the culture. They have many of the elements. They know where things are, the services. I think it's the relationships that, are the important thing to work on in training, and to understand the person's perspective of how much it means to have community connection beyond the diagnoses. I think that's the important training part.
Yeah.
But they're living amongst each other. They're having relationships, and it's strengthening those relationships that I think communities in country areas can do very well.
Yeah. I think you're right. I guess the acceptance of having a fly-in, fly-out person to diagnose is important, because we hear that people can't travel those distances for lots of reasons, whether it's cost, whether it's the way that they cope with that, their coping mechanism. But yes, it's that next step that sort of assists them in day-to-day sort of living, I guess.
I've actually found they're less likely to label each other. So the Renmark group that I went to, they were all incredibly transparent with each other.
Yes.
There wasn't an issue of stigma for them.
Yeah.
Because they share that space. They have to get along and live their lives together.
Great.
Yeah.
So, Ms Gillespie, you've got your hand up there. Please share your thoughts here. If we can, just try to keep people's comments fairly tight, because we don't have very long, and I know there's a couple more questions. Over to you, Ms Gillespie.
Thank you. So I think, look, I really hear that some communities are really cohesive and, and they are able to be very open. Unfortunately, many of us are very, very marginalised and very isolated within our communities. Sometimes our communities are not particularly safe for us. Our communities may include people who have in the past or continue to treat us abusively. Personally, I have next door neighbours who continue to stalk, threaten and gaslight me. They've threatened my support workers and stalked my support workers. I'm also a survivor of domestic violence, and my former partner lives just 5 kilometres away. So being safe in our own communities is a really complex issue. And it is not always, it can be the answer to have people who are local trained, but in the area that I live in, I say that there is not even 1 degree of, often not even 1 degree of separation. People talk about 6 degrees of separation between all people on the planet. Well, sorry, but, I'm really lucky if I know somebody, or if I meet or speak to somebody who is from the local area, and I don't just mean the next town, then, but the wider area that I live in, it's very unusual that I don't either know them or know of them from someone else. It's very, very, very close-knit. And so this is actually a really significant threat to our privacy for many of us. And this is another reason why many of us prefer to have independent support workers, and sometimes that we actually need people who are from outside our area. This whole idea of local communities supporting us, it's a really lovely idea, and if it works, that's fantastic, or, more power to it, but it doesn't work for everyone. And for some of us, being forced to have local support and being forced to have registered support is actually a threat to our very survival, and certainly a threat to our privacy.
That's really good, and I think what I was getting to in my question was around, it's not a one-size-fits-all sort of model, it is variable. Yeah, great. Ms Patterson.
Yes, Ms Patterson.
Christy Lee Patterson, Chair of Lived Experience Australia, and I think it's a blended approach. I'm a pharmacist. I've also grown up in rural regional Australia, and I've also worked in Aboriginal communities in Western Australia, Mount Magnet, and so diverse experiences there. I'll keep my comment very brief. I think into your question in terms of fly in, fly out, that can be good short term to equip the technical skills of support workers. And so when we're talking about training, there's the technical skills of training. But then I think also too with the support workers, it's allowing a place for them to be able to have continual learning. It's not just that they get trained and they get plonked into that area. They need to have continual learning. So yes, they need that technical skills first, but supporting them maybe with fly in, fly out, or even like buddy systems outside of that as well. The support workers, they also need that support for themselves. So that's a very high turnover as staff as well. They get burnt out. And so we also need to be looking at from that perspective as well. So again, it's very complicated, a blended approach, but I think bringing people in that maybe can teach those technical skills quickly, but then a continued learning approach in those, I guess, I don't want to call them softer skills because they're actually probably more important skills.
Ms Smithen, you've got your hand raised there. If you would like to add your comment, if we could keep it fairly tight, because I know there's a few questions to come. Over to you.
Yes. So first, I think in terms of training, I would say that I have a mix, but one of the issues is the NDIS pricing. So some of my workers have training, some of them don't, but I know that a lot of the psychosocial providers say that the hourly rate is not enough to include training workers anymore. So actually increasing the hourly rate for psychosocial disability workers is necessary if they're going to have the training that they used to have. And that also is another thing in terms of we've seen psychosocial providers start to hire younger workers who cost less rather than more experienced and trained workers. And that's about the pricing model as well. And then I had another thing about the fly-in, fly-out work. I have family working in Alice Springs, and they say that Indigenous communities in remote areas, they want to be able to pull their NDIS funding so they can hire support together instead of as individuals. So they would get individual funding and then they would have the ability to actually pool their funding to get the workers they need in their community. And what I also have heard from Alice Springs is that the government's not doing enough to train Indigenous people in Alice Springs to do support work. So we're seeing that in Alice Springs it's more like white people or culturally and linguistically diverse people who are going into NDIS work, but it's an opportunity for Indigenous people to be trained more into doing work there too. That's it.
Oh, thank you for those valuable ideas. And as Senator Urquhart and I were just saying to each other, that those suggestions have come up in our in Broomandarra in the hearings that we site visits we also attended, so thank you. Ms Payne.
Thank you, and thank you all for your really important testimonies today, and this information's been really useful, and it's so important that we hear these perspectives, so thank you. I suppose, and following on from Senator Urquhart's question, I want to go to you, Professor Lorne, to begin. You talked about, the fact that a lot of people don't have that, a lot of people from the NDIA and then providing supports are not living in the rural or remote communities and therefore don't understand, the situation, people's situations. But also, Ms Gillespie and others and yourself have raised the fact that sometimes you actually don't. There are also issues around having people from your own community as the only support providers available. And I guess there is a limit. We can probably do better on providing more supports locally, but there'd be a limit to how much we can do that. I guess in a practical sense, what sort of recommendations do you have, and happy to hear from everyone who would like to respond as well, about how we can improve that, And I suppose particularly with regard to the NDIA itself, like government public servants, should we have more of them based in rural and remote areas doing the planning processes, and then the workforce issue more broadly? Sorry, that's a really big question, but
yeah, I certainly know, for example, in South Australia, there's a place called Kangaroo Island, which is very used to fly-in, fly-out workers. But they don't always just fly in, fly out. They come and they stay for the week, and then they go home again on the weekend, for example. So they spend time in the community, and I don't know whether there's an idea or recommendation there where people actually, have placements or they spend time. Part of their role of serving a rural community is to actually perhaps, dedicate a week a month to being in that community, for example, or starting off establishing a connection there, having a quota of face-to-face and telehealth that is a given for those communities, for example. They might be some ideas.
Yeah. Could I very quickly respond to that one? And thank you, everyone, for the comments. I think what this whole conversation demonstrates is we're talking about regional, rural and remote as if they're all the same experience, and the reality is that every single community has incredibly different needs. There are definitely major issues with stigma and discrimination in some communities. There are less issues with that in others. The most important thing to keep in mind is that those communities currently are not empowered at a federal level around how the NDIS is delivered in their area, and there needs to be mechanisms in place for those communities to make those decisions themselves. In terms of workforce, we mentioned in our submission there would need to be specific consideration around stigma and discrimination. You can't just scale up a workforce in an area and train people in an area without tackling those issues that Ms Gillespie really revealed. But there's also a number of models that exist already across Australia. One I can think of off the top of my head was a program actually delivered in community centres in regional and rural areas to upskill the local population in suicide prevention safety training. And, the success of those kinds of models, I think, are a really good starting point as to how we can get those skill sets into local communities and actually give them the knowledge and expertise around what psychosocial may be. But the most important thing is that it can't be a one-size-fits-all approach, and we need to be empowering communities to have those decisions.
Thank you. Did anyone else want to comment on that? Ms Gillespie?
I think you might...
Sorry, I'm having a bit of trouble with the technology. I think it's tremendously, you can send people to live here, but the thing is that they're not going to live the impoverished lives that most of us have to live. People with psychosocial disability are often unable to work because of their disability, and often this is over very prolonged periods, years, decades. It's been decades since I've been able to work, and I have tried, I have tried and tried and tried. The fastest route to becoming acutely suicidal, in my experience, is to try and work. And I have to be really careful about how I do volunteering as well for similar reasons. So, living below the poverty line for decades means that we're so vulnerable to a lot of things that other people who can actually work, who are privileged enough to be able to work, and some people with psychosocial disability are able to work, which is great, but many of us are not. And so this is another way that we are marginalised and more vulnerable. Many of us have been forced to move out of cities and more populated areas, and this makes us, it further to access supports. Often this need is not recognised in the planning process, and so there is no funding for support workers to actually travel the amount that they need to get to us, or transport is not offered to access capacity building supports, for example. Many people are at risk of homelessness because of the increasing cost of living and housing crisis. And so, I think it's a good idea that people like planners and so forth actually are located in the areas that they're doing the planning for, but it won't entirely fix the problem. And one of the issues is actually very simple and very complicated at the same time, and it's respect. The number of times that we are gaslighted about things, even general discourse from the NDIA about what is an everyday expense. Actually, most of the time, the things that are construed as everyday expenses are what I would call middle-class discretionary spending, which means iPads and white goods and things like that, which can actually be life-changing and enabling for a person on a DSP who is disabled to access community or to increase their independence. And, these things are painted as if, anybody can just, you them whenever they want. Well, no, sorry, many of us cannot buy them at all.
So, look, thank you.
I think respect is the bottom line.
Yeah. And thank you. We
and
hear
proximity is important. Thank you.
My apologies cutting in there, but we're hitting our time. I can see Ms. Mithen. Can you make a very quick statement? Because I think there is one more question that I just want to allow to be asked. Go ahead.
In terms of the planners being located in specific areas, they've already tried that, and what happened is that if they let the planners just work in specific areas, these different areas build up their own average support costs and things. So the planners in a particular area develop their own planning culture, and it leads to discriminatory funding outcomes. So that happened in the past, and that was the reason why they started making the planners in the NDIS work all over, do plans for all over. So it was a problem in the past. I don't know if it was about in regions or in states, but I know that was the result, that there were the planners in different areas were developed their own planning culture, and it turned into irregularities in average plan funding that was unfair. Yeah.
Well, look, thank you for noting that. We have got the review going on now of our systems, and I'm sure that is something that is being looked into, and I appreciate you raising that. Just finally, Senator Urquhart has a final question.
I just have a question to Ms. Frith. Yes. And I'm happy for you to take it on notice and provide it back to the Secretariat. We have a great organisation based in Sheffield in northwest Tasmania, a very regional area, a beautiful Mount Rowland on the base of Cradle Mountain, doing a bit of tourism stuff for Tassie there. It's called Cause Australia. I'm not sure whether you're familiar with that, but it is an organisation that provides suicide prevention training to communities, and I'm just looking at their Facebook page at the moment. They've got training coming up in Ulverston, Beaconsfield, Cygnet, Moona, Blackstone Heights, Launceston, Campbelltown, Burnie, Railton and Smithton, right across Tasmania, but they also do it on mainland states as well. I'm just wondering on notice if you are able to provide the committee with other organisations that might do a similar thing, and that is train the communities around the prevention of suicide. If you could do that on notice, that would be great.
Absolutely. There's a number of models, and it extends outside of suicide prevention as well, so we can definitely do that.
Lovely. Thank you. Thanks, Chair.
Thank you. So, look, on that note, I'd like to thank everyone for your contribution today. I'd like to particularly thank Ms Gillespie and Ms Mithen. I understand, and I think we do understand, that to come online to this type of inquiry where you're having to speak and give us your feelings and views is not an easy thing for you to do, and we really appreciate it because we need to hear from you with your lived experience. It makes a huge difference. So thank you very much. We wish you all the very best, and we thank everyone for your contribution today. Thank you. We will now take a break, and we'll be back at 1:30. Thank you, everyone. And I think we should begin our afternoon session, our inquiry into regional, remote and rural services for people with disability. I would like to welcome representatives from the Central Australian Aboriginal Congress who are joining us by video conference. Welcome. And also the First Peoples Disability Network who are here in person today. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to Senate in committees has been provided to you. Just before asking you to give a brief opening statement and introduce yourself, I would like to just ask that we table committee the NDIS opening statement that they've provided to us. Is that okay with committee members? Yes, thank you. And then what I would like to do is also just introduce who we have with us. We have Senator Sharma, Senator Urquhart, Dr Ryan and Miss Payne, and I'm Miss Coker, the Chair. And what I'd like to do now is invite the Central Australian Aboriginal Congress, if you could introduce yourselves, and if you would like if someone or one of you would like to provide a brief opening statement. Thank you.
Sure, thank you for the microphone. My name's Andrew Jolly. I'm the Allied Health Manager here at Central Australian Aboriginal Congress. Sitting next to me is Frank Curtis, who'll be speaking to his lived experience and experience with the NDIS. And also online is Melanie Churchill, who's the Manager of the NDIS Allied Health Service. I'll be reading our brief statement, and then Mel will ask a few questions of Frank to share some thoughts on his experience with the NDIS.
Thank you.
Congress is a large Aboriginal community-controlled health service based here in Mparntwe, Alice Springs. We were established 50 years ago, and we're one of the most experienced organisations in the country in Aboriginal health, national leader in primary health care, and a strong advocate for the wellbeing of Aboriginal people. Congress delivers comprehensive primary healthcare services to more than 17,000 Aboriginal people living in Mparntwe and 8 remote communities across Central Australia. Our comprehensive approach is based on 3 interlinked strategies, which includes multidisciplinary clinical care, health promotion and disease prevention, and action on the social, cultural, economic and political determinants of health. Today, Aboriginal people in Central Australia have very high levels of disability, with 7% of those aged over 15 reporting living with a profound or severe disability. Populations bearing the burden of multiple, complex, overlapping social and wellbeing challenges are those least able to navigate the complex bureaucracy of personalised systems such as the NDIS. And in our region, Congress's NDIS, a remote community connector program, provides vital support for Aboriginal people to apply for the NDIS, as well as helping people to understand and access the scheme. As such, one of Congress's key recommendations for this inquiry is that permanent dedicated funding for remote community connector programs is secured to ensure that participants are supported to navigate the complex processes of the NDIS. Congress's strong knowledge of community, relationships built on trust and extensive experience in delivering a range of holistic, multidisciplinary and community-led services leads us to be valued for our expertise in complex care, including those supports with complex social needs. Evidence has shown that ARCHESs are more effective in delivering outcomes than mainstream services, achieving comparable outcomes but with a more complex caseload. It's for these reasons that Aboriginal organisations, and especially community-controlled health services, should be formally recognised as the preferred providers for services under the NDIS for Aboriginal people. Our clinicians also act as advocates for NDIS participants in this region, and we're often asked to write detailed reports to support initial access to the scheme. This is unfunded work. Congress has proposed an alternative commissioning approach using grant funding in very remote areas, as these areas are thin markets and market failures exist. Grant funding is a way to ensure that services can be provided so that NDIS participants are able to access the services outlined in their plans. We know that this is of particular importance in remote areas, as less than 50% of NDIS plans are being drawn on. 2 years of start-up funding for support for ARCHESs in thin markets is required to enable services to establish and learn how to charge for the NDIS. We're encouraging ARCHESs to embed NDIS services into their existing systems and ensure sustainability. It's likely that ongoing and permanent funding for Aboriginal identified roles within NDIS therapy services at Arches will be required to enable what we call a biocultural pairing model of service delivery. In addition, baseline block funding would also enable Congress to provide a safety net of services to very remote communities that have very limited access. In these regions, there's a need for allied health services to be responsive and to be able to prioritise clinical need ahead of service contracts involved with individual NDIS plans. Systems to ensure more integrated care and information sharing for Aboriginal NDIS participants are required. Central Australian Aboriginal people are highly mobile and may need to access care at different locations at different times of the year or at different periods in their lives. In this situation, ensuring that all providers have access with appropriate consent to a participant's NDIS plan is critical to ensure that people's needs are known and that service providers have access to the resources to be able to meet those needs. This will also ensure that services are not duplicated or delayed or missed. This may include, for example, that NDIS participants will have their plan uploaded onto My Health Record so that providers are aware of the services they're entitled to or receiving. In the remote context, a major challenge to effective service provision is care coordination and logistics in an environment marked by a low number of clients across a very large geographical span. In this context, fly-in, fly-out services to very remote communities are a necessity at times, but such visits need to be coordinated with local primary healthcare services and other providers who have the regular contact with NDIS participants and on-the-ground knowledge of cultural considerations. Accordingly, there needs to be ongoing resourcing of coordination and logistics to support the effective delivery of visiting NDIS-funded services to remote Aboriginal communities. There's an opportunity to get this right, and these community-recommended actions need to be implemented to ensure that there's a vital scheme that's fit for purpose across all regions. Thank you.
Thank you. Did you want to do the questions now? Would you like to do that now?
We'd love to segue to some questions if you're happy for us to. I'll hand over to Mel.
What we'll do, I'm interested to very much hear the personal perspective, lived experience, and we'll do that. But perhaps what we need to do first is go to First Peoples Disability Network and ask Miss Vanessa if you would like to just introduce yourself and provide an opening statement as well, and then we'll come back. Thank you.
Thanks. I'd like to start by acknowledging that I'm speaking to you today on the unceded lands of the Ngunnawal, Ngambri and Narragaow people, and acknowledge their ancestors, past, present and emerging. My name's Talia Rose Vanisum. I'm a Wapawara woman and the National Policy and Systemic Advocacy Manager at First Peoples Disability Network, or FPDN. I'd like to express an apology today from our CEO, David Griffith, who will no longer be appearing. End of financial year. Things prevent that. FPDN is a national disability representative organisation that represents First Nations people with disability, and it was founded on the principles of cultural inclusion and upholding our human rights. We are also a member of the Coalition of the Peaks, which is a party to the National Agreement on Closing the Gap. I'd like to start by noting that I'm an Aboriginal woman with a disability and a carer in a position of power that has been given the privilege of representing the experiences of my community members who are NDIS participants in rural, regional and remote areas on this land we now call Australia. In this capacity, on the behalf of FPDN, I share with you that the NDIS has failed for our communities in regional, rural and remote Australia. There are exceptions to this, of course, by happenstance, or by the work of driven individuals or organisations like my brothers and uncle here today, who have fought tirelessly often unremunerated to gain access to the scheme for a selected few, but this is still the exception and not the norm. It's still the case here that in 2024, 11 years after the scheme was rolled out, that the scheme assessors, plan managers don't understand us, they stereotype us, degrade us, traumatise us and facilitate our removal from country, ignore our concerns, or even worse, our goals and ambitions for the future. And that is if you can access them in the first place. And when we do, of course, the data shows that our plan utilisation rates are lower than non-Indigenous Australians, which means no matter how good your plan is, the scheme is just not working for our people. We believe that this is in part due to the lack of recognition of the number of First Nations people with disability who experience poverty. Poverty is a lived reality for too many First Nations people. Poverty of access, opportunity, as well as financial and economic means impact every aspect of our lives and therefore every aspect of the scheme. For example, how effective is an NDIS self-care or home modification support if you don't have a home? How effective can social participation be if the person facilitating it doesn't understand your social or cultural life? And how effective can therapies be if the approach being employed holds no cultural significance or value to you, let alone if you haven't had secure access to water, food or housing for the last 6 months? These conditions and concerns, while some are considered out of scope or not a matter for the NDIS, are the lived realities of many First Nations people with disability across rural, regional and remote Australia. We've said it before as FPDN, and I've been asked to say it here again today, that a scheme delivered on the basis of a market-driven approach is an absolute nonsense to our communities. Community-based models of care, capacity building and supports that integrate our care workforces and recognise the inherent value of our cultural responsibilities to care for our people are needed to make any significant change. We believe that meaningful reform for the NDIS for First Nations people with disability is achievable. However, this can only occur through genuine shared decision-making partnership that both informs design and serves as an accountability mechanism for effective and culturally responsive, safe and inclusive implementation. Earlier this year, the Productivity Commission, through its final report on a review of Closing the Gap, criticised the government for making any meaningful progress towards the implementation of Priority Reform 3, which focuses on transforming the way that government organisations work, and highlighted the need to take action if any meaningful change was to be seen for our people in the near future. The scheme's failures for First Nations people in regional and remote Australia is the physical manifestation of the government's failure to truly embed the priority reforms of the National Agreement on Closing the Gap. And as we've seen from the recently introduced NDIS bill, a complete absence of consideration and inclusion of the tailored settings required to ensure that First Nations people with disability have access to a safe and accessible scheme that facilitates a self-determined, culturally rich and fulfilling life. Thank you.
Thank you. I'd also like to acknowledge Mr. Curtis coming to us today to give us your personal experiences. And I'd like to hand over to you to actually give us your thoughts.
Go for it, Frank. Did you want to share a bit about your experience in engaging with the NDIS?
Yeah, I'd like to start off as I was up in Tennant Creek in 2022, and that's when I first had a stroke, and they had to fly me down to Alice Springs on the Royal Flying Doctor, and I spent nearly 2 weeks in Alice Springs Hospital. With that one, I had no help or anything from anyone. And I found it hard to ask for help and cry out. But I just knew Congress was here. But it's a different organisation again because the health is with NT Health. And there's different organisation altogether. Because Congress, they got organisation here, different organisation in Congress that can help us. Yeah. Because when I first come on here, I was on aged care service, and it took me a long time to get on NDIS, over 2 years. you're not crying out for the help. And I had a mini stroke, and I got speech therapists to come talk to me, to help me to gain the confidence so I can start talking, because I'm slurring at the moment, yeah.
But you're doing well, very well.
And she comes from Darwin every month to come down and talk to me. You know, we should have somebody here in Alice Springs to help us. Because they are the people from here, Alice Springs can help us. And they understand our way of living in Alice Springs. I'd like to see more at Congress speech therapists.
Yeah, we were chatting before this session about the importance of community-controlled health organisations and having Aboriginal staff. Did you have any comments about what you'd like to see for organisations like Congress and NDIS going forward?
Well, in here for NDIS section, there's no Aboriginal staff working with them. We need more to close the gap. More Aboriginal staff, I'm talking about, yeah.
Yep.
Because all other sections of Congress, they have Aboriginal workers, childcare and others, dental.
You mentioned aged care, the services that helped you get onto the NDIS. What was involved? What did you have to do, and who did you link in with?
I linked in with Dan. He's one of the workers. He took us for physio, and he pushed hard for me to get on the NDIS. So it took almost 2 years to get on. He was the voice for me.
Can I ask you, so why did it take so long? What were the barriers to you accessing the scheme?
Well, it takes a long time in Northern Territory and Alice Springs. Some people have been waiting for more than a year or 2 years, and they're not even being recognised.
Frank, it's Senator Urquhart here. Can I just ask you, when you first finalised the paperwork for the application for you to go on to the NDIS, did you then get a lot of questions coming from that? Is that what the delay was? Or did you have to wait for medical advice to see specialists, and was that the waiting? Can you just talk me through what happened during that period of time from when you applied to when you actually got it? What were the impediments and the steps along the way?
Well, I had to get doctor report and the hospital report on what I needed to do, and also with Congress to see if I was eligible to go on the NDIS.
And was it the hospital in Alice Springs and the doctors in Alice Springs, or did you have to go to Darwin or somewhere else to get that medical support?
I had to get the I had to get the support from Alice Springs Hospital.
Right. Thank you.
Could I ask you, Mr. Jolly, you mentioned about baseline block funding. You talked about systems of integrated services across remote regions. You talked about the need for fly-in, fly-out coordination and greater coordination and logistics support. Are you able to touch on those things? We're obviously looking for solutions here to better support people like Mr. Curtis. So can you touch on those things and give us a little bit more information about how they could support people with disability in regional remote communities?
I sure can. Congress over the last 2.5 years, I think we saw a vision that integrating NDIS and disability services into primary health care and a community model of care is really important. And I guess our recommendations are stemmed from our experience over the last couple of years. I think the representative for the First Nations People with Disability Network mentioned that that it's a market-driven environment for service delivery, and I think we felt we were keen to be competitive in that space, and we're quite keen to embark on delivering services as an Aboriginal community-controlled health organisation. But there's been significant barriers to being successful in that space, and I guess our recommendations are consistent with our learnings to sort of maybe make it a bit easier for other Aboriginal community-controlled health organisations to step into NDIS service delivery. I think we feel really strongly that services that are integrated with the other services available through primary health care are important. I guess we also provide aged care services. You heard how that was a useful tool. Dan, our physiotherapist, was able to work with Frank and help drive forward and push forward the process of gaining access to NDIS. Our aged care service is block funded for allied health, and it means that we can securely employ our staff. And I guess the foundational funding environment, funding context makes it very easy for us to deliver that service without the concerns of wondering whether it's feasible or not. So I guess our suggestions and recommendations for some startup funding and some block funding means that we can provide a safety net. It means that we're a little bit more in a stronger position to employ the staff that we need to provide the services, irrespective of whether they're attached to people's plans or not. I guess our recommendations for fly-in, fly-out service providers, one of the good things about the market-driven approach to NDIS sector services has been the influx of a whole lot of service providers. The volume isn't quite there to be sustainable for people. There's still delays for people like Frank, but we feel really strongly that they need to be coordinated with community models of care, and primary health care is one of the stronger community agents, particularly services like Congress being an Aboriginal community-controlled health organisation. So we feel strongly that the coordination of those visiting services is really important and key. We think there's some efficiencies by coordinating people's visits. They might be able to share the transport if they're different providers, for example, or they might be able to coordinate with the clinic to understand if there's any changes in the community with people's availability.
Well, thank you very much. Senator Sharma, have you got any questions you'd like to ask?
Yeah, I did have a question, if I might, Chair. Thank you. And thanks to the witnesses for appearing today and your work with the submissions. I was just curious, perhaps starting with the Central Australian Aboriginal Congress. Obviously, service delivery in remote and regional Australia and Central Australia is challenging across a range of issues, whether it's health, education or the NDIS. I guess, what are the sort of unique challenges that are particular to the NDIS versus the more, generic challenges that exist across service delivery channels in non-urban communities?
It's a pity Mel can't speak to this. Mel's our NDIS Allied Health sort of manager. She can. I've gotten thumbs up. I'll throw the mic to Mel.
Okay. Hi, can you hear me right?
Yes, I can, yep.
Yeah, thank you. Some of the challenges, I think, are that there are so many providers now in Alice Springs and there's a huge disconnection of services. It's really hard for them to talk to each other because we don't have centralised ways of talking. So, for example, in Alice Springs, I'd say sometimes we have too many service providers and out in the very remote communities, not enough. Right. So one of the issues with a market-driven approach is that it's very easy for organisations to come into Alice Springs and start up, but there are no requirements for them to coordinate their services with each other, and so communication is a real problem. And one of the reasons that we have asked for access to people's plans to be made, say, available in the health system is so that we can integrate between systems. So, for example, if somebody comes into Congress and they haven't accessed their NDIS services for a year because for whatever reason that person has either disconnected with their services or that service provider's left town and not told anyone that they've left town, that happens quite often, that Congress is in a position to reconnect that person in.
Yeah.
At the moment, the barriers to that are quite large, and the waits to reconnect into NDIS can be pretty hard. That's just one thing. I think some of the other barriers for access are that the scheme itself I don't think is particularly understandable, and I don't think people really get what their plans are. I've sat in NDIS planning meetings where planners have said, oh, what are your goals? Are you happy with the goals? And then the person sort of nods quietly and says yes, and then I've had to ask them, do you know what a goal is and do you know what your goals are? And the answer is no. So I would suggest that a large number of people under the NDIS have very little comprehension of how it's structured in the first place, and especially when it comes to understanding what's a consumables budget, what's a capacity building budget, what's this, that and the other. I'd say there's very little understanding of that. It's too complex, I think, and it needs to be simplified because it's a very sophisticated bureaucracy that most people really, I don't think, can get their head around in an easy way.
That was a very common thread that we heard at the Broome and Darwin hearings, was around people not understanding, but also the language that was used. People don't necessarily know what that word is, and if it's not in their own language, there may not be a translation, so it became very difficult. So, sorry.
Oh, that's all right. That's a useful clarification. Just on the sort of sharing of data and knowledge. So at the moment, can you upload your NDIS plan into My Health Record? Like, what happens if your provider leaves town and you need to find a new provider? Like, and do you help? Does your Congress, does your body help with that, like transferring people over to new providers?
Yeah, so our remote community connector program has been funded to do that work. Which is why we have requested for permanent funding for that program. So that team is the people that we can refer to as clinicians when, for example, like I said, someone comes into a clinic who's disconnected from their NDIS supports, and now we do have that channel. It's still really time-consuming work to refer to them. Their list is huge, so it does take them time. But there is now that avenue, which is really good, and that's a team of Aboriginal people as well, and that's really important. Their effectiveness as local Aboriginal people is so much greater than those of us from non-Indigenous backgrounds in terms of connecting and helping people to get through their NDIS systems.
Yeah, okay, understood, thank you. And just finally, I saw in your submission one of your proposals is to use grant funding in remote areas rather than where there are thin markets and market failures, so I guess outside of Alice and other parts of Central Australia. How would that work? Because I think you suggested it could be like almost like sort of startup funding to get these services off the ground, but are there enough users of the NDIS to have these services financially viable once that grant funding is over?
Yeah, it's an interesting question. We've sort of got, I guess, almost a two-part recommendation there. The first is for what we've suggested would be a 2-year grant to help organisations get started with the NDIS. Mm-hmm. So, for example, I've been with our NDIS team since the very beginning. We officially started doing NDIS 2.5 years ago now. We are large enough that we can absorb some of those costs, but we are not yet anywhere near profitable. So we are definitely not breaking even, and it's my job to try to turn that around. So that's 2.5 years in, and as a large organisation, we have not been able to make a for-profit model work for lots of reasons. But one of the things we would like to see in terms of ongoing funding, like a baseline level of funding, would be so that we can employ Aboriginal people in our team, as Frank has recommended. Mm-hmm. At the moment, NDIS doesn't have a mechanism for that billable model, so the billables all come with the clinicians for us. Yeah. And unfortunately, we don't yet have a workforce of local Aboriginal clinicians. So one of the barriers to our service delivery is that we don't have those that bicultural pairing model. We're not able to have Aboriginal liaison officers within our team because the billable model doesn't enable us to employ them. So that would be one of the uses of it. Right. One of the other uses of a baseline model, of like a baseline level of funding, would be for us to be able to service those remote communities that are not financially viable for a private provider. So, for example, if a small community has maybe 2 or 3 people with NDIS plans, but a private provider can't make a profit out of seeing that community, those people miss out.
Yeah.
And I think we have an obligation as an Aboriginal community health organisation to service the needs of the people, whether or not money can be made out of it or not.
Yeah. Thank you so much. Thank you, Chair.
Yeah, thank you very much. Handing over now to Ms Payne.
Thanks very much. I'm keen to ask you, Ms Vanessum, you made a really important point that the NDIS cannot work where we haven't closed other gaps, and you made really important points around that. So I just want to acknowledge that, because that is going to undermine the way that the NDIS can support First Nations people. So I don't know if you want to comment further on what priorities might be, or how that, I think that's a really broad area, but was there anything further you wanted to say on that?
Yeah, for sure. Thank you for providing me the opportunity to do so. I think that echoing brothers and sisters here from the Congress is that we are supportive of, I believe it's recommendation 9.5 from the Disability Royal Commission, but don't 100% quote me on that, around block funding for our community-controlled organisations to make sure that not only they can employ and strengthen our sector in terms of getting Aboriginal people into jobs and caring for mob, but bridging some of that gap and understanding more of that needs gap between what the scheme can provide and what is missing in terms of the poverty levels, and bridging some of that through brokerage or different alternative commissioning models. We're supportive, FPDN's supportive of alternative commissioning, which the NDIA has started to explore, but there has been issues, I guess, from our perspective in implementation, is that there's no kind of cultural oversight. The First Nations Advisory Committee that NDIA has set up hasn't been linked in or connected to that project at all. It happened completely outside of it. So what's the point, I guess, is kind of so making sure that when we are entering partnerships and stuff with mob, that it connects to the services that delivering and it serves a purpose and it's not just advisory for the sake of it, is one of our big things that we're going to be working hopefully in partnership with the NDIA to try and address and improve this year. I know that other people also mentioned the disconnect in language between what's being delivered and what's not. I think when we did some consultations for the NDIS review, it didn't matter whether things had been translated into language or not, it still didn't make any sense. And I think that not to say that we don't need things in language, I think that just goes to show how much of a disconnect between Western conceptualisations of disability and care and First Nations concepts of disability and care that there is. And if you've got a Western product and you translate it, it's still meaningless. It needs to be from a First Nations cultural perspective and then translate it, because then we understand what's going on. So without that, we still have that kind of fundamental disconnect. And I guess that's another thing that we'd really like to see more of as well, is investment in the disability sector strengthening plan. So we created that in partnership with government under Closing the Gap. I believe it was released early last year.
Sorry, could you repeat the name?
It's the Closing the Gap Disability Sector Strengthening Plan.
Strengthening Plan.
Yep.
Thank you.
And it has actions in it which are extremely broad. Were criticised from the DRC and Productivity Commission, rightfully so, because they're not measurable, implementable and results-based, but we are committed to working with government to re-looking at that and making sure that we can actually lay out a pathway forward to improve the sector and build a talent pipeline for amazing organisations to be able to utilise. We haven't seen any kind of investment in that plan. So making sure that that can be rolled out is another massive focus for us as well. But we need to recognise that not every single person mob care have been caring for people with disability since time immemorial without a physio degree. We don't need every single person that's caring for our mob to be qualified to the nth degree. We need people to be recognised for the care that they're already given. So,
thank you.
That's interesting. In the previous session, we talking a lot about getting the balance right between people in rural and remote communities having access to supports from people with the qualifications that they need, but also recognising that everyone doesn't need qualifications. So, I take that point.
Yeah, we also speak about how there's often a low expectation of people with disability and recognition that they're also carers in our community. We have such high prevalence rates that focusing on getting mob with disability into those jobs that have lived experience that they can help in different ways is also something that we're really concentrating on. We've got examples in communities here of people with intellectual disabilities but are physically strong helping out mob with physical disabilities that can't carry or clean things, where the person with the physical disability helps the person with intellectual disability fill out all their forms and connect them to different things. So just like those things are already happening in community, but recognising them, they might also be receiving a support payment because they're unemployed. Like, that's a job right there. So recognising the strengths within our communities already and funding those. It's just articulating it through that market-based approach, which is nonsensical to us.
Yeah, and I was that was my next question actually, was that you said that a market-based scheme is a nonsense to communities. So can you expand on that, and how do you think, and would it be, I understand we've heard evidence around individualised plans are something that people would like to see people would like to see plans pooled or plans brought together so people can arrange supports together. Is that something you agree with, or
I'm not across that,
okay.
so I'd have to. Yeah, I can take on notice kind of FPDN's position on that, but that's a new one for me. Yeah.
Well, would you just around the market-based scheme? So do you feel that the NDIS doesn't work, or are there ways in which you'd recommend it be altered for communities to?
It needs to be altered to work, and I guess that when we talk to people, it's with if talking about profiting from providing care for our mob is quite frankly disgusting. When we talk to people, that's how they feel. They feel exploited, and they feel that it's also monetising cultural responsibilities that we've had for a very long time. So when there's that recognition piece and that cultural translation piece that hasn't happened, it's hard to kind of speak on it. But when you've got I guess they were talking about the economies of scale, when you've got the 3 people in the region, no one's going to go and set up a service to service 3 people on country, but you could, in theory, employ their family members that are already there to provide care and get training and resources that are there through alternative commissioning approaches. We've also spoken about at previous hearings culturally thin markets across the entirety of Australia as well, rather than just the thin market language in regional and remote, because we often hear that our mob with disability have to choose between being Aboriginal and being a person with a disability to access a service when they want to come as they are to an Aboriginal service and get their disability needs met as well.
Yeah. Okay. Thank you. Did the witnesses from the Central Australian Aboriginal Congress want to add to any of these on any of those issues? To comment? No.
No, just that I think the concepts of pooling plans and some of those hybrid ideas about using the individualised plans for people creatively, I think they're interesting. But we know that grant funding is a model of operating for Congress that works. It's a bit more simplified, it's not as complex and doesn't rely on so much coordination between people, A, having access and B, having enough room in their plans to be then joined together. I just think the more simple that we can make the funding mechanisms for these sort of services, the better, from a kind of that's a service provider's perspective within Congress. And the last thing I'd say is there's real synergies between I guess both the NDIS and the Arches sector are both kind of underpinned by empowerment frameworks. It's about rights. They're different sectors in a way, health and disability in some ways that we talk about it. Because of that rights connection, I think I just wanted to reaffirm that connecting community control and NDIS makes a lot of sense to us, and we're really committed to looking at ways and advocating for ways to make it sustainable.
Thank you. Have a quick addition to that, if that's okay, because you triggered something for me. Is there a... Now it's gone. Now it's gone. Don't worry about it. It's disappeared. It will come back to me.
Come back to it.
Yeah, I'll leave it there.
Yeah. Thank you. Dr. Ryan.
Thank you, and thank you all for your testimony. Can I ask you, Ms Venison, so I guess with the new NDIS legislation, there has been concern from many parts of the sector about the extent to which co-design and consultation will be enshrined and the need for that respected. And it's been an ongoing discussion in the House and the Senate. In the previous session, we were talking to some people with lived experience who had expressed or described difficulties when you've got a small community and there's only so many carers, and with the conflicts of potentially privacy and people being uncomfortable about disclosing their needs or being represented by other members of a relatively small community. Would it be fair to say that might well be an issue for First Nations communities?
It's fair to say that that issue could exist, but it would be dependent based on the community that you're in, what relationships exist, what cultural avoidance law exists, and a bunch of factors. That's one of the reasons we advocate for place-based co-design, is so that they can have those discussions and let them know which models will work and which don't. I remembered what I was going to say before. I was going to add that on, was about the individualised and the pooling of plans. We very much do have something that links to that, and often when you're talking about First Nations disability data, identification rates and prevalence rates are really, really low. There's a lot of issues with data collection and identification. And I've been asked, how do we get more people with more First Nations people with disability to identify? And our response to that question, it's less about making people do anything and just having the supports there ready for people to access. So I guess around block funding and making sure that our organisations that are on the ground, they know that what people need in their community, and if those supports are there, then people don't need to identify and do all of these other exhaustive processes. But obviously the way that funding works at the moment, that process is needed in order to distribute the funds to that region in the first place. So
yes. But how would, if I'm not a member of the government, but if I were a member of the government and I was trying to work out how much funding to provide to a specific community, how will the government do that if it doesn't have useful information about how many people are likely to need to access that funding and what their needs are likely to be?
I'd say there is information, but it's not in the format that we're used to respecting or acknowledging and holding at that level to inform those decisions. So it's more qualitative rather than quant, and it's info coming straight from the ground rather than from surveys, or where there are surveys that are collecting that stuff, investing money into making sure the modules are accessible for mobs so that you get data that is actually useful. At the moment, I'm pretty sure SDAC doesn't represent regional and remote communities, so SDAC is the main data survey of disability, age and carers, which is where a lot of disability data comes from. It doesn't represent regional and remote Australia. We know that there are issues with identification across all surveys for mob. So if you're not going to invest in that, and then you're not going to use the qual info either, then we just end up in the same situation that we're in now, going back and forth about what the need is versus what government is seeing.
Right, so maybe the government should speak to local health organisations and things like that who are better equipped to say who's around and what their needs might be, and to provide some input into that?
Yeah.
Okay. The other thing is, in terms of the co-design and consultation process, wanting to make sure that it's optimal, and to what extent would you suggest that the government needs to, in terms of First Nations consultation, what sort of level of granularity would that require? Does that require going to, there are many, many communities, does it require going to every community and doing something individually with that community, or in the absence of an overarching organisation that can speak to the government about the needs of each community, how best to make sure that is culturally sensitive at a community level?
For us, and I think it's 9.10, but that's off the top of my head. I haven't got it written down in front of me. There's a recommendation from the Disability Royal Commission about a First Nations Disability Forum that could potentially fill some of that gaps. It's also got a partner recommendation in the NDIS review. I believe it's Action 20.4 potentially, around establishing a First Nations Disability Forum that can help guide some of these questions. For, as a member of the Coalition of the Peaks, any partnership or co-design that starts anywhere needs to be adhering to the stronger partnership principles within the National Agreement on Closing the Gap, which means funding our organisations to have that voice and participate in that going up. We would love to see you need overarching bodies to make sure that communities aren't being isolated and that best practice is being shared. But when it comes to individual that should never override what a local community thinks needs to be in their community and their voice to do that. So we have the housing policy partnerships and the justice policy partnerships for Closing the Gap. Our key principles when we're sitting at those tables is nothing that we come up with here should override the voice of a local community and what they've asked for. So in those spaces, different jurisdictions fund different areas to have that voice and to work with them to implement things. But because disability is so cross-cutting, it often gets lost. And because the NDIS is seen as kind of a scheme and put to the side when you consider the totality of the First Nations disability ecosystem, there's that continual disconnect. So there aren't any bodies that exist that fill those kind of gaps at the moment.
Can I just step in there? Mr. Jolly and Mr. Curtis, I can see you nodding there in agreement. I just thought, did you want to add something in there, or Mr. Curtis?
You have anything to add?
Not really. It's straightforward anyway. Sam? Yeah.
No, we're just liking what we're hearing, and I suppose just throwing in there, I guess from that, there's varying capacity across different arches across the Northern Territory that we're familiar with. But look, Congress is in a strong position to participate in co-design and shared decision making, and we've been able to facilitate a disability reference group to really hear from people just like Frank and get information on our own service delivery. And I suppose one thing I'd mention is not to duplicate those mechanisms for community engagement, utilise what already exists and where the strengths are, and in cases where there may be varying capacity for community organisations, Aboriginal community organisations, I think if the NDIS could contribute to strengthening and building capacity using NDIS language there, that would be a really great win-win.
Thank you. And Senator Urquhart.
Yeah, just a really quick one. I just wanted to ask Mr. Curtis, given that it took you a couple of years to get on the NDIS, can you just give us a little overview of how your life's been improved by that?
It's improved a lot. I just got to work on my speech more and my balance on walking.
Yep. But you're getting improvements from that. I mean, we can understand you very well, so your speech is very good, but I'm sure that you'll keep working on it. So.
Yes, I will, because when I ring up and talk to people on the phone, they always ask me what my name is. Greg? Yeah. But I say, no, I've got to spell my name out. Yeah.
I'm laughing because I haven't had a stroke, but when I say my name on the phone, my name's Anne, and people think I say Ian. So I understand how you feel.
Yes, we all have those challenges, I think. But look, I think I just wanted to say on behalf of the committee that what we are very pleased to know, Mr. Curtis, Frank, that while it did take you some time and probably too long to get onto the scheme, that it is supporting you and it is making a difference to your life. That is very good to know. And our aim is to continue to work to actually improve the services that go to you and others in regional remote areas. And your help in giving us your first-hand experiences is very useful. But thank you to all of you for your contribution today. It will help us in our recommendations that we will put together and table a report in coming months. So thank you very much for your time this afternoon.
Thank you.
Thank you.
And we will suspend just for a few minutes while our next witnesses come forward. To you, and thank you for being here so promptly. We'll start just a couple of minutes early. I would like to welcome representatives from the National Disability Insurance Agency. I'd just like to introduce the members of our committee. We have Senator Sharma, we have Senator Hughes, Senator Urquhart and Ms Payne, and myself, the Chair, Ms Coker. So I understand information on parliamentary privilege and the protection of witnesses giving evidence to this committee has been provided to you. And for the Hansard record, if you could just state your names and in what capacity you appear today, and I would like to invite you then to do a short statement to the committee, and then we'll take some questions.
Thank you, Chair. Fleur Hill, Acting Deputy CEO for Service Delivery.
Tanya Malthouse, Branch Manager, First Nations Group.
And Mark Wiggins, Branch Manager, Market Stewardship.
Thank you.
Thanks, Chair.
Go ahead.
I'd like to begin by acknowledging the Ngunnawal and Ngambri people as the traditional custodians of the lands we're meeting on today, and pay my respects to elders past, present and emerging of all Australia's Indigenous people. I extend that respect to the First Nations people in the room with us today. Thank you for the opportunity to appear today. We're pleased to discuss the work the agency is doing to improve the outcomes for people with disability living in rural, regional and remote areas, as well as the further reforms we have underway to continue to enhance our service models. The NDIA is deeply committed to making sure that participants in remote communities have the same access to NDIS supports as people in other locations. but we know that can be challenging, and the workforce challenges in remote communities experienced are across the whole range of service systems. As covered in the Social Services Portfolio submission, the NDIS effectively has two delivery streams. One is enabled through partners in the community, which includes our LACs and our early childhood partners. This is the model that participants in our cities and regional centres access. The other stream is directly delivered by NDIA staff, and that's for our participants in remote and very remote locations. The NDIA's remote servicing model was initially released in 2015 when the scheme was still in trial in many locations. That model is built on a dedicated network of NDIA remote planners who engage directly with people in remote areas, over 200 remote community connectors who cover more than 400 communities, an early childhood trial that is occurring in the Kimberley and the Torres Strait, and strong partnering with Services Australia to share resources and deliver more holistic services in remote areas. With the scheme now being at full rollout, we're working earnestly to strengthen and enhance that remote services model. Whilst we've built a foundation, we certainly acknowledge that more needs to be done. Access to the NDIS, to disability supports and other mainstream services in remote and very remote areas remains a challenge, and we recognise that this is most deeply felt by First Nations people and their communities. We are in the process of implementing an enhanced remote servicing model which will expand our remote coverage and improve our services to more communities. We recognise we hold significant accountabilities under the National Agreement on Closing the Gap, both the socio-economic targets and the priority reforms, that we need to operate in a trauma-informed way, and that we've been given strong advice by the sector on what our remote service offer should include. To that end, we have established dedicated, geographically tied teams to service remote Australia. They all include place-based presence through an expanded Community Connector program, which was a recommendation of the Disability Royal Commission, dedicated and specifically trained planning and support staff, and a new function to engage in the local community-level stakeholder space with a view to addressing barriers to service delivery through partnerships in a really targeted way. The NDIA now has our first First Nations Deputy CEO for the agency. Narungga Ghana woman Dr Janine Mohammed was appointed as the NDIA's Deputy CEO for First Nations in April of this year. Dr Mohammed is committed to creating a culturally safe agency and ensuring that First Nations participants have equitable pathways to join the scheme, to receive services and feel respected, supported and heard. The agency remains committed to co-designing an updated NDIA First Nations strategy with First Nations NDIS participants. We have been working with the First Peoples Disability Network and the First Nations Advisory Council on its development. The updated strategy will replace the inaugural 2017 NDIA Aboriginal and Torres Strait Islander engagement strategy. Recommendation 14 of the NDIS review explored better ways to commission supports for First Nations participants across Australia and for all participants in remote communities through alternative commissioning arrangements. In August last year, the Minister for the NDIS, the Honourable Bill Shorten MP, announced Maningrida in the Northern Territory as the first of 2 alternative commissioning pilot sites. The pilot at that location has commenced with discussions with key leaders and individuals in the Maningrida community in collaboration with the Department of Social Services, other government agencies and the Northern Territory Government. We will be looking with the community at options for far more locally driven activities such as coordinated funding proposals and direct commissioning. Whilst this pilot occurs, we're also ramping up other resources, such as the rollout of access clinics, which will help people with disabilities in remote areas to more easily access the scheme. Since the Social Services Portfolio made our submission in February, our quarterly data with regard to rural, remote and regional participants has been updated. As of the 31st of March, there were 9,888 NDIS participants living in remote and very remote areas, representing 1.5% of all participants across Australia. Of these, approximately half identify as Aboriginal and Torres Strait Islander people. There were 70,016 NDIS participants living in regional areas, representing 11% of participants. And there was 124,496 participants living in rural areas, representing 19% of participants. Like all reforms the agency is undertaking, we will need to ensure we make the changes I've talked about today in close consultation with the communities we support. We have a dedicated approach to co-design and engagement in the NDIA, and working with local community groups, traditional owners, Aboriginal community-controlled organisation and other stakeholders is a key principle in how we design place-based solutions. The NDIA looks forward to the report and recommendations of this committee contributing to improvements to the scheme's delivery, and we thank the organisations and individuals who have taken the time to provide evidence.
Thank you very much, Ms Hill. Mr Wiggins or Ms Malthouse, would you like to add to that opening statement in any way?
No, thank you.
I think so.
Okay. I'm just hoping you could table your opening statement for us, because I think that would, you've got some fantastic data in there which could be very useful. Before I hand over to my colleagues, I was going to ask you, we've had a number of the witnesses this morning state that people in regional, remote, rural areas are not actually fulfilling they've got a budget and they haven't been able to actually spend it. And really, I think the reason is that there is workforce shortages and other challenges in terms of travel that is making it difficult. And I'm sure you're aware of this. I'm wondering, what have you thoughts about how do we actually ensure that those plans are actually able to be fulfilled? So we provide good services to people on the ground in their communities.
Absolutely. Utilisation under the scheme ranges from around 80% in big cities to around 60% at the other end in very remote locations. There are two ways we tend to engage in that space. The first is through alternative commissioning and market facilitation measures. So for those remote communities where we are seeing low utilisation, the remote planning teams that I spoke about in my opening statement will go in and have conversations with those communities and say, look, you've got 50 providers here. That's too many providers to be in this space this small. Do you want to choose one that you want to deliver your services? That then gives a single provider enough market share to come in and consistently deliver an ongoing service for those participants. So that's what we would refer to as a coordinated funding proposal, and that's one of the measures that we're looking at really trying to promote and utilise in very remote communities. So alternative commissioning approaches are really important in lifting that utilisation in remote areas. The other pathway that we're progressing in tandem is looking at how we can mobilise local workforce to deliver... Sorry. I'll wriggle in a little. The other stream that we've got in place and are working on is on local employment measures. We know that in a lot of these remote communities, we have a high number of people on the community development plan, so not in paid employment. And a lot of those people would not require specific skilling or training to deliver a lot of the daily living supports under the NDIS. So what we're doing is working with those local community development program providers to try and workflow people from that program into local care sector roles. So two-stream approach, both alternative commissioning and local employment markets. We know we've got a lot more work to do on it, but those are the ones we're starting with.
And those teams, how many of those teams are established, and, to give us a sense of...
Yeah, absolutely.
How effective and how broad-ranging it is.
So at the moment, we have 5 teams in Queensland, 3 in New South Wales, 6 in the Northern Territory, 5 in South Australia and 8 in Western Australia. The staffing of those teams has gone from 75 people nationally before we rolled out this program. We're currently at around 150 staff applied to that program. Once we're fully staffed in the public service sense, we'll be just over 200 staff, and we will supplement that with additional community connectors to build on that place-based connection.
And have you found that where you have involved teams within regional, well, really remote and rural communities, have you had successful outcomes, and can you provide us with that sort of detail on where it has been successful and why?
So the program is still quite new. We've been rolling out the teams in the course of this calendar year, so still quite new. What we do find is that we get a different type of engagement in communities when we go out with those teams. So rather than planners turning up and saying, I'm here to do your plan, let's talk about that, we have our planners go out and talk to the community and say, how do you want us to work with you? What are your priorities? Who do you want us to be working with? And it starts a different conversation. It lets us look at more than just the individual plan. It lets us look at the community as a whole and what they need to have viable markets and service providers. And we're certainly seeing the alternative commissioning trial site at Maningrida is a really good example. We're seeing when we go in and we talk to community in those terms, they're very engaged. They've asked us to be a signatory to their local decision-making agreement, which we've done, because we're giving that signal that we're not just about this transactional piece of work, we're interested in the broader environment and we want to help you build that.
And hopefully that it is not just a one-off, that you will continue to return to basically ensure that the success of what you started out to do.
Absolutely. So we'll have consistent presence in those communities through our remote community connectors, but we have the same teams because they're geographically tied. The same people go back to the same place multiple times per year to keep that connection there and make sure we're tracking in the right direction.
And do you have First Nations representatives in these teams?
We absolutely do, and we've really focused on having First Nations leaders in those teams.
Thank you. I just have one more question before I hand over to Senator Hughes. Are you able to provide me with, you talk about those remote community connectors, the RCCs, and I'm aware that there is, there's 460 remote communities and you've got 205 of these RCCs from what I've researched. Can you tell me how are they working and the projects that are in place, and any examples of things that are working?
For sure. So remote community connectors for us are an absolute cornerstone of our remote servicing strategy. The RCCs are First Nations people who are working in their home communities, so they're not people who lob in for a visit. They're there all the time. This is their spot. They are known and trusted. They largely work through local Aboriginal community-controlled health organisations. We spend about $11.8 million a year contracting across 37 organisations for those services. The roles vary place to place based on what that specific community needs, but there are certainly commonalities that all our RCCs have. So the first of those commonalities is that they undertake a cultural brokerage role for us. As the committee would be well aware, respectful and effective engagement means that we keep that conversation going. We have a consistent presence. We don't just lob in and do transactional work. So the RCC presence and ongoing connection with community is really important for us in that sense. The second things that all RCCs do is around the foundation local information sharing function around the NDIS. Because RCCs are local and they're part of the community, they're trusted and they can explain the scheme in a way that makes sense on the ground for those people. Many First Nations cultures have a very different conception of disability, and what RCCs can do in that circumstance is bridge the gap for us and explain locally what the scheme is and how it can support residents. The third really important part of the RCC role is feedback back into the agency to tell us what we're getting right, what we're getting wrong, and what that specific community needs. The other types of things they do a lot of supporting participants in appointments with providers. They do translation, they do explanation of what the provider is saying. They can provide advice on the documentation that participants are engaging with providers on, which is a really important function. They undertake participant check-ins in a wellbeing sense for us. They help identify people who should be on the scheme and link them back into the agency. They connect participants to other local services, which again, really important in making sure we have holistic supports for people. They're absolutely instrumental for us in setting up access and planning clinics. And they create local connections. They can link us up with the local CDP provider or the local clinic or the local school in a way that's quite difficult if you come in cold. So into the future, we are expanding that program. At the moment, we have the 37 ARCHOs under contract to provide those services. We certainly intend to continue those services. The ARCHOs are a really important partner for us. But we also intend to build on those contracts and have directly employed RCCs as well. This will both expand our footprint in the places where we haven't been able to contract those services from ARCHOs, and it offers a stable, ongoing local employment option for First Nations people in those communities. Following some really successful trials in Western Australia, we're also rolling out what we're calling a local community connector role in some of those larger remote centres that have a more diverse demographic. We know the RCC is the right fit for First Nations communities, but with that more diverse demographic, we need a job that looks a little bit more like a local area coordinator to form that connection function where we don't have partners in the community. There will absolutely be places where both those roles are appropriate, so places like Catherine in the Northern Territory, you have a large mixed demographic population, but you also have a lot of people who come in from country to access services, so it's completely appropriate that we'd have both roles functioning there. As I said, the Royal Commission certainly recognised these roles as important and effective and influential, and we couldn't agree more with that. We very much value our RCCs.
Look, thank you. We have been to Darwin and to Broome, and the RCCs sound like they are very effective where they're based. However, I do think that in a number of communities, the rollout, we need to do it faster in some communities. So we found that there were First Nations people that, struggle with the language of the NDIS and building trust with members in those communities is at times very challenging. So wish you well in establishing more of the RCCs. I think that the more we have in those remote communities, the better. But on that note, I will hand over to Senator Hughes.
Thank you, Chair. Thank you for being here today. Ms Hill, you just sort of started to answer part of my question, because the opening statement and a lot of the commentary you just made at the beginning was very focused on First Nations, and there are people who are not First Nations that live in rural and regional and remote parts of Australia. So I was just hoping if you could perhaps expand a little bit outside of just a First Nations focus on the way that the agency is looking at participants and their families in rural and remote areas.
For sure. So as I said earlier, there are those two streams. For where we have a partner in the community and an early childhood partner, the agency does the planning part of the process, but community connection, that initial access to the scheme, that happens with a partner. So for participants in rural areas, that's the model that they would access. For all participants in those areas that we would classify as remote, very remote, and some of those regional areas, this service model that we're rolling out is for everyone. We use the design principle that if we design for the most vulnerable, that system will work for everyone. Whereas if we do the converse, we do have people who slip through the cracks. So for people who are not Indigenous people in those areas, they can absolutely expect that same tailored service. They can absolutely expect they will have an end-to-end planner who will work with them through access, through planning, through reviews. The system is designed to work for everyone.
And so can non-Indigenous people access the RCCs at this stage? RCCs, sorry?
So the RCCs at this stage operate in First Nations communities. Right. So there are very few non-Indigenous people in those communities where the RCCs are based. That said, if we had people who were in those communities, yeah, we would expect the RCC to be working with them as well. But that is one of the reasons that the local community connector model is important to work in tandem, because yes, First Nations communities, we know we need that First Nations presence. For those larger demographics with different types of demographic mixes, we want something that looks more like that partner in the community model, doing an LAC-like job, and then we can supplement as we need to.
Okay. We've heard from people today and at other times expectations of what the NDIS will pay for. And I guess, one of the questions I had today and some of the evidence we heard today was delivery costs not being covered. Now, I would have thought that wasn't covered by an NDIS plan. But I just wondered whether or not you could outline, there's been a lot of talk about travel with regards to service delivery and what is actually part of the NDIS plan and what is not part of the NDIS plan. If you could maybe sort of outline expectations around that.
For sure. I might actually ask Mr Wiggins to have a talk about those pricing structures for us.
Yeah, sure. So in terms of I've been tuning into the discussion today. There's, let's say, 3 categories. We've got the cost of contracting or engaging supports. There's travel allowances, which apply to delivering those. But then there's also the other programs that Ms Hill's been running through. So I can talk about the
I guess I was surprised to hear someone was talking about incontinence equipment, but then, was sort of horrified that the NDIS wouldn't pay for delivery, whereas I would have thought that wasn't part of your NDIS plan. You pay for the incontinence pads, but not special delivery because someone doesn't get Australia Post to their door.
We might need to take that specific query on notice. Continence aids are certainly covered for some participants under the scheme, but I recognise your question is about how they get there, so we'll come back to you on that one.
Yeah, because I think sometimes there's a lack of clarity as to what the NDIS will fund versus what the NDIS will fund to be supported, but not the activity itself or the support and the swimming lesson, not the swimming lesson, I guess, is the easy way to think about it. Sorry,
just to clarify, so if we come back on that, it's not so much about delivering the supports, but it is specifically consumables.
Well, that was just one of the examples given today, but it was given by someone in the context they live on an island that's only accessible by ferry. Well, the Australian taxpayer, should they or should they not be funding additional costs on delivery? But obviously that's going to have impact in other areas as well. So just to sort of clarify, would be helpful what is responsibility of the NDIS and what isn't. One of the queries and concerns raised, and I sit on a couple of committees that look over the NDIS and Senate estimates, so I kind of get it from all sorts of areas. But there's certainly been a concern in rural and regional areas about foundational supports and the states having to step back up and provide those supports, but especially in rural and regional areas where community health now no longer exists and these, allied health professionals aren't on the ground and there's no private providers in town. What work has the NDIS been doing or the agency been doing to have a look at, once these foundational supports are supposed to be stood up, what's the impact on rural and regional areas that just simply don't have them?
So the responsibility for the policy around foundational support sits with the Department of Social Services. So while we will absolutely engage really closely in implementation and advice at the time, those policy decisions sit with the Department of Social Services.
Okay, so the agency hasn't been sort of working to do a bit of an analysis on the areas where you've got pockets of participants that might be impacted should they no longer have NDIS plans and be relying on foundational supports.
We absolutely provide advice and input to the Department of Social Services, but that policy and what the intention is for foundational supports is not something that we as a department can speak to.
Right, and there's not data sharing there for where areas need to be focused on or particular you know, Moree in far west New South Wales or Emerald in central Queensland, there's no sort of analysis of what's available in each area or numbers of participants in areas given to DSS?
The Department of Social Services has access to whatever our data they need to plan that policy. And as I said, we do provide advice into that process, but it's not our process to speak about.
Yeah, okay. And I guess just to clarify something that was just said by the previous witness who was First Nations, one of the suggestions was paying family members. And I'm happy for you to take it on notice, but I would have thought that was outside of the remit of the NDIS.
So the agency is in the process of looking at a family members as support workers policy. That's obviously one that's really complex and that we need to consult broadly. Generally speaking, the region...
I'd love to get paid to be full-time care. You don't know, but I'm just a parent.
Generally speaking, the reason that we try to avoid family as paid support workers is the safeguarding question, because we want people to have a broad network of supports and range of people who can speak up for them. And when we limit that network, that's greater risk for the participant. What we do know, though, is that in some locations, in some circumstances, for reasons of failed markets, small community, cultural needs, sometimes there just isn't someone else who is suitable. And we know that's not going to be most of the time, but we do expect that will be some of the time. So the policy that's under development at the moment is delving into those complexities and developing an agency position on that.
Because, you know, you wouldn't want a situation where parents are charging the taxpayer to look after children or...
Agreed. This would be a policy that was for quite a limited range of specific circumstances, but we do recognise that those circumstances exist for some people, so we want to be able to cater to it.
Okay, thank you. Thank you, Chair.
Thank you. Questions?
I'm happy to go first if you want me to.
Yep. Go ahead.
Just one from me, and I'm not sure whether it's a question you guys can answer or whether it's a DSS, but earlier we had witnesses who, there's lots of organisations out there that support people with disability, and it's prior to people getting on the NDIS. So it's about the support that they get in writing applications if they're not able to do it themselves or have somebody within their family or, you know, anyone that can do it for them. A lot of organisations are doing it unfunded. Is there a path or anywhere within the NDIA processes that actually covers off on that, or is that a DSS issue?
So our advice to people seeking, and I'm thinking you're talking about access to the scheme.
Yeah, so it's prior to them getting on the scheme, but actually making the filling out the application and the paperwork process.
So where participants have a partner in the community, we would absolutely say go and talk to that partner in the community. They can support you on the access.
So when
pathway.
you say a partner in the community, what do you mean?
So we have contracted organisations in metro, urban, rural areas.
Yes.
And their job is being the front face of the scheme to the general population.
Okay.
So they have local area coordinators. They also have people who can help with those general access queries and tasks.
So these are the NDI sort of shop fronts and places like that. Is that what you mean?
Not all of them are branded NDIS. A lot of them are just community organisations that deliver a service.
Right.
But where a person has a partner in the community, we would absolutely say go and sit down with them and they can help you do that application.
Okay, but the question then is, they can help them do it, but what about, because I know a lot of those organisations have very tight sort of parameters around the streams of funding. They get lots of grants from everywhere. Where does that fit? Is that...
The grant work is separate from what we contract those organisations to do. So they are specifically...
Do you contract them to help people fill out the application, is the question I'm asking then?
Yeah, that is part of their job. When people come in and they say, I have a disability, I think I need to access the scheme, that partner in the community should walk through a community connection process with them.
Okay.
And if they need to apply to the scheme, they can say, OK, we will need you to bring in this piece of evidence and this piece of evidence, and we will fill out the form and we will get it in the system.
Okay, so on notice, can you provide the committee with the, state by state or whatever, who those partners in community are?
Absolutely.
That'd be great. Thank you. Thanks, Chair.
Thank
Ms Payne.
Thank you. Thanks very much for being here this afternoon. I'm just interested in your opening statement. You talked about the alternative commissioning trial, pilot, sorry. And I was just wondering if there's any, if you can expand on that and if there's any sort of way forward coming out of that at this stage yet, or
Absolutely.
any findings.
So we're quite early in the trial process. We've started community consultations, so we've gone into the community and sat down with traditional owner groups, with the local health clinic, with groups of community members, and we've talked to other service providers in that community about what they see as the gaps and the needs and what they want services to look like. Consultation on projects like this tends to be repeat business, so I expect we will do 6 months, a year of conversations like this before the community is in a position to say, okay, we understand what you're on about, this is the thing we want to have a go at first. So we're early in the process, but what we are pleased with is the fact that we've got really good engagement and take-up in the community. When we're going out and having events, people are turning up. When they had their local decision-making agreement come up for signature, they wanted us to be part of that. They wanted us to be recorded as working in that space. Did you want to add to that, Mr Wiggins?
Yeah, I guess the elements of the alternative commissioning approach is having at its core, at its heart, a culturally safe and appropriate approach. So the decision, the funding allocation included resources to train and equip NDIS staff to engage appropriately. We're recruiting First Nations people into the teams. And I guess the thing about the alternative commissioning approaches is we really, as Ms Hill was saying, it's about sitting down and allowing the community to identify the priorities and the sorts of solutions that are most appropriate to them. And it's about, I guess, avoiding the mistakes of the past where you sort of have a tendency to want to solve problems and go in and solve problems rather than give and provide the space and build the relationships to surface what's actually going to work in that community. And I think that's the thing that defines the alternative commissioning projects from past efforts.
Right, thank you. I guess another issue that's come through is around the low take-up of the scheme in First Nations communities and the underutilisation of plans. And I was wondering, is there anything that's being tried or done about that at the moment?
For sure, and those are both issues we're very conscious of. We know that our data that we have and we look at, there's a lot of indicators in there that says we're under in remote communities. We should have more people on the scheme there. So the remote services model that I was talking about with increased resources and place-based presence helps build trust in the community, which makes people more willing to talk to us, more willing to have the conversation, understand the scheme and eventually gain access. Obviously, government organisations don't walk into these locations from a position of trust, so we need to take the time and put the effort in to build that, which is the process we're embarking on now. In terms of those utilisation approaches, the alternative commissioning approaches are really where we need to be looking. We have, in a lot of remote communities, large numbers of providers offering services, which means that individual participants are all going off to different providers. No one gets a critical mass that lets them deliver a viable service there. So when we use alternative commissioning approaches and we have participants who want to pool their funding and go to one provider, that gives them a more consistent service. So instead of having someone who comes in once a year and then you don't see them, you can have an organisation that comes in once a month and a whole number of people get services from that organisation once a month. And over time, as we build local capacity, we can have more of those services delivered locally rather than fly in, fly out.
Thank you. That sort of comes to earlier today. We were talking with, which was the organisation? It was the Lived Experience Australia, around how, there are issues with when you've got people from the NDIA but also support providers who don't live in the rural or remote area and don't understand. And one practical suggestion that they made was that maybe it could be that people come and spend a week there a month rather than fly in, fly out. Is that something, or more broadly, is there anything the NDIA is considering around addressing that, or and is that particular proposal something you could consider?
Yeah, so one of the things we've been really clear on with our remote servicing teams is that they are required to travel. They are required to be out in community, and that's a regular travel schedule. So that's a bit of a different service proposition from what we've talked about before. Mm-hmm. In terms of providers, we obviously can't control how they operate their service model, but we can absolutely talk to participants about how they exercise control over their plan and who they can choose to fund and support to be coming into their communities. And I think that's a space where we do have a lot of scope to be working with Aboriginal community-controlled organisations to establish partnerships with some of these other providers to build local ability to deliver those services rather than continually relying on services from out of community.
Okay, thank you. I'll leave it there. Thanks, Chair.
I just had one question. Dr. Ryan, do you mind if I ask a question now?
I just wonder if I
You go ahead, because you haven't had an opportunity to put your question yet. Go forward.
Thank you. Thank you for your testimony and your work on this important area. We often hear about, and we've heard multiple times today, about people's concerns about the nature of the carers and providers that are given to them. And I guess the tension between people wanting to have choice about access to providers in areas where there's thin markets and the training requirements for people. My question is, I guess, is do you see yourself as the agency as having any role in supporting people in their training as providers, or is that something that you basically would feel more comfortable leaving to other parts of the education sector?
So we certainly have a provider engagement part of the organisation that works to make sure providers understand their accountabilities under the scheme and how we operate. We also work quite closely with the Quality and Safeguards Commission, which is responsible for registration of providers and regulating that market.
Yeah, I guess I get that, and it's important that people be vetted and that we make sure that people who are engaging with the system as paid providers are appropriately screened and all. I guess what we were hearing is that many people would like to, they're happy with carers who are relatively unskilled or who maybe the only people that they can find in a relatively small community are people who don't have, a whole lot in the way of formal qualifications. But we're also concerned that those individuals need support and that they're more likely to be retained within the system and to give, for the quality of their service provision to improve over time if they're given professional support, training, I guess pathways for professional development. Is that something that the NDIA engages with at all or not?
Did you want to respond to that one, Mr. Wiggins?
Look, I think that's an area that's really managed by the NDIS Quality and Safeguards Commission. It's not something from, I guess, the market stewardship perspective that we're focused on. So, no, I can't really add much.
Okay. Thank you.
Today we've heard from a number of organisations that have talked about greater need to coordinate health professionals going into communities, and there was an example given where you might have a speech pathologist going into a community. There'll be a community nurse who may be there at the same time. Someone will have someone going into the home and giving support. But it is, the sense is from what has been mentioned today that a lot of those services can be quite fragmented in the way that they are going into a community. And when you have communities that are quite remote, and these services and the face-to-face presence of these health professionals is like gold, really. So I think it was quite a pertinent point that was made was, you know, it would be great to see greater coordination of these health professionals coming into community that then can help the largest number of people with disability at the same time. Makes sense to me. How do we, you know, is that happening in communities, in some? How do we make it happen across the majority?
It's a fantastic question, Chair. Look, as you've said, it is really tricky and it's such a disparate environment sometimes. Where we see that work successfully is where we have strong local organisations that speak for the community with a really clear voice. One of the approaches that we're certainly taking with our remote servicing teams when we go in is to say, be really clear on what's a priority for that community. And if that community says to us, coordinated visits and servicing is what we need, we don't want it to be patchy like that, then that team will finish their visit, they'll come back and they'll say, right, who do we need to talk to? We'll talk to State Government Health because they're sending some people out. We'll work with the local ARCHO. We know there's another organisation out there. We probably need some education coordination. And they can work locally to try and herd those cats, so to speak, and do something coordinated.
Those foundation supports that we're talking about are really important to get more input from state and territory to make these services work and to have them coordinated. I mean, it seems to make sense. And the thing that I also know that we're all very passionate about is early intervention, because when you have early intervention, you can get such better outcomes for people with disability and consequently families as well. Like it is crucial. But often in remote and rural communities, getting that early intervention is more challenging. So can you tell me a little bit about, is that a focus with the scheme, and is there anything particular that's being done to improve those outcomes in terms of early intervention?
For sure. So in remote and very remote areas, we have two early intervention trials for children underway. One is in the Kimberley. It's run through the Kimberley Aboriginal Medical Service. The other is in the Torres Strait, run by the Torres Strait Hospital and Health Service. Those are both trial programs that we've funded to try and pull out I guess the strengths that actually work in a remote environment in an early intervention sense. The agency has a children's task force, and there's obviously a huge amount of work looking at the early intervention pathways as a response to the NDIS review. Part of that work is absolutely looking at a standardised early intervention approach for kids in remote areas.
So we would be, I think we would be very pleased to any information you have about those projects, where they're at, the outcomes that you're wanting to achieve, and to come back and give us further information as to the outcomes of those pilot programs and, you know, how do we then roll them out more broadly, those type of successful programs.
Happy to, Chair.
Has anyone got any other questions that they would like to ask? The only other one I wanted to ask was there is a question that a number of the services asked about having like baseline funding for providers in some of these more remote communities, that they're saying they could be given to a flexible services that they can deliver in those communities. It's been raised when we were in Darwin, it was raised when we were in Broome. I'm just wondering, baseline block funding is what the terminology was used.
Yeah.
Can you give me your thoughts on that?
So the agency doesn't block fund services. We see that as a measure that puts control with the service provider rather than the individual. But we do have alternative commissioning measures that can yield a similar result. So the coordinated funding proposals we've been talking about, where a number of participants pool their funding and work with one provider, is one of those options.
And that was right, that's been raised today?
Yep. The other option that the agency has is what we call direct commissioning, where we say that there is market failure for this service and we will contract an organisation directly to deliver that service. That would then give that one organisation enough funding to be viable. When we make those decisions, obviously, and I don't believe we've direct commissioned much at all in the agency's history, but looking at those direct commissioning options, obviously we would be looking for local control. We know local services, Aboriginal controlled services, deliver better outcomes for First Nations people.
And are there examples that you could provide to us, of those where they have been put in place? Like, for example, how many of that direct model how many of those are currently underway across the nation?
The thin market trials that were conducted a few years ago basically had three different types of market interventions they were testing, which was facilitating markets, which is about trying to connect people better, the coordinated funding proposal, so getting people to cooperate to procure. And we had, I think there was a couple, or at least one direct commissioning project, which was in the APY lands in the north of South Australia. That contract is still running. And I think it's fair to say that it was able to go in and provide supports in an environment that was just not viable otherwise. Not just the small number of participants, but the fact that they're so distributed around the APY lands, there wasn't a sort of concentration. So it was a very difficult sort of provider prospect. And so NDIA commissioned its Catholic Care in this case to come in and provide supports to a number of participants. It's sort of seen as a least best last resort type model because, as Ms Hill was saying, once you commission in a provider, you're essentially foregoing choice and control. You're sort of locked in for that. Now, when the alternative is no service, then that may be preferable. But I think what we're focusing on doing is getting better at identifying what are the local solutions, using coordinated funding proposals, which can in effect achieve the same results. And we were talking about
that was highlighted as something that was a meaningful, effective way of providing services with support of the actual participants. And so is that a growing initiative? Are there many communities using that model?
It's certainly one of the models that there's a number of different, I guess you'd call them sort of market intervention or market facilitation exercises around the country. We've got the alternative commissioning projects that are Project Maningrida that's up and running. There's 4 sites as part of the Integrated Care and Commissioning Project, which is a collaboration, I guess, or a recognition of the need to align services between disability, aged care, veterans and some health elements. And so basically saying when you're in a thin market, if we can at least align some of those comparable support needs, then that gets that critical mass. And so And then there's a range of other market facilitation sort of interventions that get made. And so CFPs are increasingly seen as not just an effective way to improve viability, to increase a bit of participant market power by having consolidated and being a buying block instead of an individual. But also, when we're looking at remote communities, much greater capacity to meet and share travel costs and so on. And so you can make trips more efficient and you can share costs more equitably. So while commissioning is definitely a tool that is available, it's really seen as that sort of, when all else fails, how do you put in a floor type thing?
Well, I think we'd probably already all agree that these communities, from the experiences and discussions we've had, are very different, and what they want and their needs are different. And so, I mean, I'm pleased to hear that you're going into communities and they're individualised approaches for different communities. I suppose the challenge is going to as many of those communities as you can and as we can to create I suppose better service models for people who live in those communities, and that is the challenge. We're a big country, but we do need to do it. So I'd like to thank you, unless anyone has any further questions they would like to put. I'd like to thank you for your time today, and if you can provide us with any background data or information about those different key ways in which the NDIS is achieving better outcomes for people in those remote communities would be of value to us. And I'd just like to thank you very much for your time today. Is there anything I need to say in wrapping up? So basically in concluding, I'd like to thank you for your time. As mentioned earlier, where witnesses have taken questions on notice, the committee requests that information be provided within 3 weeks by July the 19th. However, do liaise with the Secretariat if you do need additional time. I would like to thank Hansard and Broadcasting for assisting us today, but also the Secretariat, who do such a great job in supporting us in our roles. So thank you very much, and thank you to my colleagues for being with us today.
Thank you, Chair.
And the committee stands adjourned at 3:23. Thank you.